Hi friends. So now we're going to start with microbiology. I feel this is one of the subjects that's very scoring in the exam, and you'll find that a lot of questions come directly from what we're going to be studying. So very high yield, very important. Don't let this one go because I've seen that in the last few years the micro questions have been pretty predictable. You haven't gotten any bouncers or anything twisted really. So becomes very scoring. So do this video very well. So we're going to start with bacteriology, follow it up with mycology, parasito and virology, and then little bit of general micro towards the end. Along with this, I'm going to also cover, integrated vector based diseases in this video itself, right? So infections I've covered like here and there. TB, HIV, the main bulk will be covered in the PSM video, whereas all the vector-borne entomology part, everything will cover in this only, right? So that's how you'll find the infections getting covered. So let's start with bacteriology first. Before that, a general bit about stains and microscopes. So what you see here is our standard light microscope that I'm sure you all would have at least worked with once in your life. So this is what is our standard light microscope, whereas this is what we call as the electron microscope, right? So it looks kind of like a missile. That's how you remember it's electron microscope. Now, when we talk about light microscope first here, I'm sure you all know the parts, but just to give you the orientation, they can ask you sometimes a question when they can tell you to arrange it from bottom up or vice versa. So we just need to be oriented with the names. So this is where you have the light switch here. This is the light source. What is very important is the condenser, because this condenser, if I change this condenser, I can also get what is called as dark field microscopy. Okay, so right here, let's just complete when we are going to study dark field microscope for treponemes, particularly in syphilis we do dark field microscopy. It's only the condenser that we change, rest of the microscope remains the same. Okay, so that's what it is. So this is the condenser, and then you can see here this is the stage clip through which the light is going to pass. And now you have the objective lens which you change. So there are 4 objective lens that you can see here. So this objective lens could be either 4x, 10x, 40x and 100x. So these are the 4 objective lens options that you have. When you use the 4x, this is what they call as the scanner. This is the lowest power, right? So you get a scanning view of the slide. 10x is what they refer to as low power. 40x is what they refer to as high power, and 100x is what we need oil immersion for, right? I'm sure you've at least done this in your path, once. Otherwise, just remember this. So 4x, 10x, 40x and 100x are the objective lens. And then you have the eyepiece through which, or the ocular lens through which we are going to see, which also offers another fixed 10x magnification. So the ocular lens offers another 10x magnification. So this is what is important, that whenever I'm doing a traditional simple light microscopy, what we are seeing on the slide is essentially the transmitted light. All right, so this is what is the transmitted light. Whereas in dark field microscopy, when I change the condenser, we are working with the reflected light. All right, so this is what you need to know about light microscopy and the concept. Now let's do a comparative analysis of light microscopy versus electron microscopy. So the fixative, you must have smelled it in the path lab, for light microscopy slides is your formalin. So that is what we write as 10% NBF, neutral buffered formalin. So if you essentially remember that it's formalin, that's good enough, 10% formalin. Whereas for electron microscopy, the fixative that we use, electron microscopy, the fixative that we use is 2.5% glutaraldehyde. You can remember this right here, right now. We are going to be studying sterilization in a while. So side X is 2.5% glutaraldehyde, right? So that's what we are using here. So glutaraldehyde 2.5% is the fixative for electron microscopy. The slide that you use obviously here is made up of glass. The only thing you remember, in electron microscopy, we are using copper, because electron microscopy, the electrons are not going to travel through matter. They can, but not here. They are traveling through vacuum. So this missile-like thingy has vacuum inside, right? So we need special material. So that's what the copper is for. Resolution is important, right? So here you want to remember in light microscopy, it's 0.2 micrometers. Same number now becomes 0.2 nanometer. So that's how the resolution is much, much higher in an electron microscope. Talking about the magnification, so we have already done, depends on the lens, right? So as we said, the ocular lens gives us a fixed magnification of 10x, whereas the objective lens could be 4 different options. So one more time just to revise, 4x was our scanner, 10x was our low power, 40x was high power, and 100x was the oil immersion. So if I ask you what's the maximum possible magnification that we can achieve, that's 100 into 10. It's always a multiplication. When it passes through both of the lenses, the total magnification gets multiplied, right? So the total possible maximum magnification becomes 1000x, right? So this is what are the principles about light microscopy. Two special types of electron microscopy are scanning and transmission. So internal structures, which one would show us? Obviously when something gets transmitted, right? So that is what we call as transmission electron microscopy. And 3D, when we are scanning something. So 3D image is scanning electron microscopy, right? So this is what we need to remember about electron microscopy versus light microscopy. Going on to general microbiology about the stains and the cell wall structure. Very, very important. So first, let's get stains out of the way. You had a neat question a couple of years back about gram staining. So what you are seeing here as this image is gram stain, okay? And we are going to compare it with modified Zeal-Nielsen stain, right? So modified Zeal-Nielsen and gram stain, the steps. The first stain is called the primary stain. The primary stain, or just to remember the order first, remember for gram stain our mnemonic is come in and stain. You are standing outside path lab and what does the pathologist or microbiologist say? They say come in and stain. So you remember come in and stain, right? So the primary stain here is crystal violet. Okay, so there is crystal violet as the primary stain. Mordant here is iodine. Iodine fixes the crystal violet. Decolorizer is acetone. Now people might confuse this. Was this acid? Was this acetone? Both are A. So you want to remember Zeal-Nielsen we say is acid fast, right? So this one can't be acid. So that's how I've remembered that this can't be acid. So this is alcohol or acetone. And counter stain is saffronin red. The only thing possible from S that you might know. So that is why anything which is gram positive, like you can see here in this image, are gram positive bacilli. So anything which is gram positive is going to retain the crystal violet. Mordant is what fixes the primary stain, and if it gets decolorized, it will appear as the counter stain. So gram negative will appear red or pink, whereas gram positive will take up the color and retain the color of the primary stain. That's the concept. Modified Zeal-Nielsen, the mnemonic here will be came. You are calling na come in and stain. So you came. So that's what you want to remember, that here it will be came. So what is the primary stain now? So you can see how the bacteria here are staining pink. It's fuchsia pink. Yeah, girls would know this precise shade of pink, which is fuchsia pink. So this is how you remember that this is carbol fuchsin. There is no mordant here, it's just heat. So heat acts as a mordant here to trap the primary stain. The decolorizer is acid. Which acid? The strongest acid, which is H2SO4. And counter stain is M. You can see from the background here, it is methylene blue. We can also use malachite green if the background is green, right? So in this case, it's blue. So this is what are the steps of Zeal-Nielsen stain. All right. So now, just to finish off acid fastness, what are all the things which are acid fast? You can remember from this table. And we also target the question, arrange an order of acid fastness. Okay, so if we know the percentage of H2SO4 needed for decolorizing, that's the strength of acid fastness. So the most acid fast is TB, which requires 20%, highest strength of H2SO4. Then comes leprosy, which is next, which is 5%. And I've also added Cryptosporidium isospora. This is differently from what I said in the first edition. because it's a little controversial, okay? But I think this is a better answer, where Cryptosporidium isospore are considered to be 5%. But I couldn't find like solid evidence in any, literature as to why this is 5%. So if you have any reference, you can share it with me. But this is what you can follow as of now, okay? Because this is what most faculty have taught. So Cryptosporidium isospora will be 5%. Nocardia legionella is 1% H2SO4. So Nocardia legionella, this is probably the only thing I want you to remember. TB, leprosy, are acid fast. Nocardia is acid fast, legionella is acid fast. And now look at this. Bacterial spores have spur. Head of sperm has spore. Let's make it sperm from today. We have Cryptosporidium isospora. So I can say anything with a spore in it is acid fast. Nocardia legionella and TB leprosy I already knew. Yeah, so all of the things which are acid fast now I know. Bacterial spores and head of sperm are 0.5%. They are the least acid fast. They need the minimum strength of H2SO4. Okay, so these are least acid fast is what you want to remember. Cold acid fast is where I don't use heat as a mordant. This is called as the Kinyun's modification, and this is what we use for coccidian parasites. Coccidian parasites means Cryptosporidium isospora. These, remember, are going to be the causes, and we'll study them also. These are going to be the causes for diarrhea in immunocompromised patients like HIV, AIDS. Okay, so this is what you want to remember. Cold, Kinyan, coccidian parasites, right? So this is all about acid fastness here. Now going on to gram positivity again and core bacteriology. So what makes any bacteria gram positive is the cell wall, which has peptidoglycan. So you want to remember, peptidoglycan is the main element which gives anybody gram positivity. So look at the gram positive bacteria. They have a larger, thicker peptidoglycan layer, whereas it's very thin in gram negative, and that is why it gets washed out. Okay, so this is what is the reason for gram positivity negativity. Let's understand the other differences. So now you can see that common to both is flagellum, pilus and capsule. Peptidoglycan is different in them. Unique to gram positive, hasn't been ever asked but sounds important, is lipoteichoic acid, which gram positive has, whereas gram negative, very very important, has endotoxin in the cell wall. All gram negative have endotoxin, except what is the only gram positive which has endotoxin? So you want to remember, all gram negative and Listeria. Listeria is the only gram positive bacteria which has endotoxin. The endotoxin is made up of three parts. You want to remember OCA. O for O antigen. Remember how in Vidal we do H antigen, O antigen. So the O antigen actually comes from the endotoxin. So these are the three parts of the endotoxin that we are discussing. So you would be wondering, what is the H antigen then? So H antigen is the flagellum, right? So H antigen is what is the flagellum, whereas O antigen is what is the component of the endotoxin. C is the core polysaccharide, and A is what is the lipid A. So if somebody will ask you what is the most important part of endotoxin, obviously A. A is always most important, right? So lipid A is the most important part here. One extra point that you want to remember here is the flagellum stain. So for the flagella, we have one more stain which is called as Leifson and Rue. Alright, so Leifson Rue stain. Flagella and Leifson, right? So this is what is a stain, extra point here, just as we're talking about flagella. So flagella is what is important for the locomotion, for the movement, whereas pilus is what acts as a virulence factor. Okay, so that's the difference. Both are not used for movement, right? What else? So here, apart from endotoxin, you can also see that gram negative has sporin, which is unique to them, and they have this periplasmic space. The periplasmic space may contain beta lactamase, and you also want to remember this periplasmic space has endoflagella. So whenever we hear endoflagella within, It is in the periplasmic space, and this is what is a feature of spirochetes, right? So spirochetes endoflagella, particularly treponema, is in the periplasmic space. So that's the point here. Two extra points. Linulus amoebocyte assay. This is something which is an assay of endotoxin, right? So this is what can test. This is sounding like a potential INICET question. Okay, so this is what is used for measuring endotoxin. Diaminopimetic acid is the unique amino acid that is unique to bacteria. Nobody else has it except bacteria. Now, when we talk about endotoxin versus exotoxin, you want to remember just this one box, and that breaks down the table of endo versus exotoxin. So this is all that is describing endotoxin. Have you ever heard of any vaccine or toxoid against endotoxin? No. Why not? Because it has low antigenicity, low toxicity. I can't make a toxoid or vaccine, whereas exotoxin like diphtheria toxoid, tetanus toxoid, I can make. This is heat stable. Why is it heat stable? Because it's a part of the bacterial cell wall. Is bacteria personally heat stable? Yes, it is surviving in heat. So the endotoxin is also heat stable. And when will it be released? It will only be released if the bacteria lyses, because it's a part of the cell wall. So this is what is endotoxin. So once it releases, it's gonna give rise to a downstream reaction which is involving all cytokines. So IL-1, IL-6, complement. So it's gonna just induce complement reaction and all of your inflammatory cascade, right? So this is how endotoxins work. Now we're going to talk about exotoxin. Before that, there's just this one line, because it's the only place where I had extra space, so I've just put it here. Remember, we are going to study a whole bunch of gram-positive cocci. There are only 3 which are gram-negative cocci. So you want to remember Manvi. We'll talk about Mansi in a while. This is Manvi, okay? So Manvi is an exception here. So what do we mean by that? What are the 3 gram-negative cocci? One is Moraxella. Most important that we are going to be discussing is Neisseria, and then you have something called as Veillonella. So Veillonella is useless. Neisseria is very, very important. And Moraxella, one thing we'll discuss in ophthalm is what it causes, angular conjunctivitis, right? So that's what, apart from that, it causes like upper respiratory tract, okay, infections. So this is about the endotoxins. Now going on to very, very important slide here, which gets you like a lot of questions are about the toxins, okay? So every exotoxin, so here's where I'm talking about exotoxins. Exotoxins don't have a standard run-of-the-mill reaction. They are going to have specific actions depending on which, depending on how they bind and what are the downstream reactions. So this is what is very, very important. So every exotoxin has 2 subunits. B subunit is for binding. So that's how you remember. B is for binding, whereas A is for action. And they've asked this in context of diphtheria. But you can remember that this involves ADP ribosylation. So this is one of the repeat questions as to how the binding action is happening. It's because of ADP ribosylation, right? So this is a side point. So now binding has happened. How does it act? So what are the toxins which inhibit protein synthesis? It can either be by elongation factor 2 inhibition or 6-TS ribosome inhibition. Very, very important. So 2 toxins which inhibit elongation factor 2, the most important is diphtheria toxin, like 1000 times asked question, very, very important. And another toxin which has not been tested, which acts like diphtheria, is Pseudomonas exotoxin A. So Pseudomonas exotoxin A also acts like diphtheria and inhibits elongation factor 2. Now let's discuss a few points about diphtheria toxin. So diphtheria toxin, we can do this gel precipitation test. What is the name? This is called as Alex gel precipitation test. Yeah, where you will see such an image. They can ask you this image-based question. Alex se hi we can remember Schick, right? So Alex Schick test is a cutaneous sensitivity test, again for diphtheria toxin, right? So Alex and Schick. And also remember that diphtheria toxin's action is related to iron levels, right? So it works well in iron depleted medium. So this is what we need to know about diphtheria toxin. What are the toxins which inhibit protein synthesis by inhibiting 60S ribosome? S. So S for Shigella toxin. So Shigella toxin binds to this If Shigella is this, won't Shiga-like also be this? Yes. So Shiga-like toxin also inhibits 60S ribosome, and Shiga-like toxin can also be called as VLT. VLT matlab Viro line toxin, right? So who produces this Shiga-like toxin? It is produced by enterohemorrhagic E. coli. EHEC, and that is why they also cause hemorrhage, meaning dysentery, just like Shigella. So this is EHEC, which produces a toxin which has same mechanism and presentation, clinical presentation as that of Shigella. Which EHEC variant is very, very special, very famous? That's O157H7. Don't memorize this, just remember 7 and 7 come, right? We have to mark it in the options. We don't have to memorize it. So O157H7, SIRCE7, SIRCE S60S, right? So why is this so famous? This is famous because this is the most common cause of HUS. What is HUS? Hemolytic uremic syndrome. If you know the full form, you know everything about this. Hemolytic anemia, yeah. Uremia. In fact, I don't even need to write this. Hemolytic anemia, uremia, and what is it doing anyways? It's doing dysentery, right? So this is what is the triad. You have bloody diarrhea, hemolytic anemia, and uremia. That's HUS for you. So this is what we need to remember about EHEC, and we are going to discuss this further when we go to E. coli. Going on to toxins which increase the level of CAMP and hence cause secretory diarrhea. So this we can remember from the name itself, CAMP. We do little cheating and make it CALP. So C, A, L and P. So C is for cholera toxin. From today onwards, you are going to call cholera toxin as COT. Why? Because COT is ZOT. What does that mean? We have discussed this in physiology, where I said that cholera toxin acts on zonula occludens. Okay, so this is COT is ZOT. If you have ever attended offline meeting, no, microbiology is the first subject which I teach. Why? Because cholera, this is the first slide, okay? So this is because cholera is GM1 ganglioside, whereas I teach biochemistry on the second day. You know why? Because GM2 ganglioside comes in biochemistry. Where? We just finished biochemistry. Where did we study? That was Tay-Sachs, right? So Tay-Sachs, Sandhoff was GM2. Second day. First day, micro cholera. That's how you are going to remember, okay? So, 2 points about cholera. Cortisol acts on zonula occludens and acts on GM1 ganglioside. A, simple, is for anthrax toxin. L is for the heat labile toxin of ETEC. LT, toxin of enterotoxicogenic E. coli. T for toxicogenic. L for heat labile. T for traveler's diarrhea. Alright, so ETEC causes traveler's diarrhea. We'll study that. P for pertussis, right? So pertussis toxin again increases CAMP. Pertussis matlab whooping cough. Here you will have an inspiratory whoop. Remember, when we cough, what do? We do a forced inspiration followed by a forced expiration against closed glottis, which increases the pressure and the glottis opens. So that's how you cough. So here that whoop, inspiratory whoop, can sometimes be so severe that it can lead to apnea in babies. So this was once a question, that which infection can actually lead to apnea in babies. So we can remember this right here, right now, that it's pertussis, Bordetella pertussis, right? So this is about CAMP. We know M and L go together. This is the first place where you're studying M and L go together. We'll see a lot more today itself, right? So this is about CAMP. If there is CMP, there is CGMP increase also. So what is pending? Do you agree? One LT is there, means ST must be there. So we finish it off here itself. So heat stable toxin of ETEC is what is going to be increasing CGMP. So this is finished. Going on to toxins which inhibit the neurotransmitter release. So who inhibits neurotransmitter release? First of all, the mechanism here is there are these snare group of proteins which are responsible for exocytosis, right? So that is what is inhibited. So now, which neurotransmitter? If I inhibit acetylcholine and if I inhibit GABA glycine, the impact is going to be opposite. Because acetylcholine helps us contract our muscles. So when I inhibit acetylcholine, what kind of paralysis will we have? We are going to have complete weakness. There's going to be flaccid paralysis, right? So this is what is caused by botulinum toxin. Many times asked. So botulinum toxin, Clostridium botulinum. So BT inhibits the release of acetylcholine and hence you have flaccid paralysis. So can you see this floppy baby here? So this is what the presentation would look like. You're gonna have this flaccid paralysis. Talking about this further, the botulinum toxin causes a descending flaccid paralysis. Okay, so it starts with ptosis and then it goes down. So whenever we study descending, remember we studied it in snake bite of cobra crate neurotoxins. There also it was descending and here also it's descending, right? So when we talk about the types of botulinum, we can get botulinum from canned food. When canned food is stored for a very long time, what will happen? The toxins are present as preformed toxins. It's already there. So you can remember we stored the can for so long that now the spores have germinated and the toxin is ready. So as soon as you eat it, you're gonna develop it. Whereas infant botulinum frequently happens if you feed a newborn baby honey. There's a cultural practice in a lot of places where they don't breastfeed directly. The first feed, the baby is given honey. So that's what leads to this infant botulinum. Whereas wound, if you fall down, you may get botulinum through spores. So both of these, it's spores. So just remember that canned food is preformed, everything else is spores, right? So this is what we need to know about botulinum. Whereas if you inhibit GABA and glycine, now we are inhibiting the inhibitory neurotransmitter. So there's going to be no inhibition, there's going to be no relaxation resulting in spastic paralysis. This is done by one bacteria and one forensic toxin. So spastic paralysis is our tetanus toxin, right? So tetanospasmin, the name itself tells you. So they'll never give you tetanospasmin, they'll give you tetanus toxin. So one is tetanus toxin and one is strychnine. Okay, so we have strychnine and we have tetanus, which cause spastic paralysis. Tetanus, we write it as TE. So you want to remember TE is pre-E. So tetanus causes presynaptic inhibition of release, whereas strychnine is post-synaptic. Okay, so that's how you remember that TE of tetanus is pre-E of presynaptic, right? So this is how the mechanism of strychnine and tetanus differs. And as you can see here in this image, how this will present as this opisthotonus. This is what is described as this lateral curvature, opisthotonus. You may have lateral curvature like pleurosthotonus, right? So these are all the posturing and persistent spastic paralysis that can happen with tetanus and strychnine. Last part is super antigen. So what is a super antigen? First of all, look at how a normal antigen behaves. Okay, so this is what is the antigen binding site on the B cell, and this is what is the T cell receptor. So every cell has this specificity. All right, only when this is recognized will there be a downstream activation. So you can see this is how the T cell gets activated. But look at these super antigen guys. They are like, I don't want any specificity. I am the mafia. I am super antigen. So this is binding to the site and activating every possible T cell which we have. So this is going to result in a diffuse release of IL-1, IL-2, IL-6, TNF alpha, all of your inflammatory cytokines. So this is how they result in a toxic shock syndrome. Diffusely, you're going to have cytokine release, you're going to have fever, and you are going to have a shock-like presentation. So super antigens result in toxic shock syndrome. There are two bacteria which produce super antigen. One is Strep pyogenes, which is your group A strep, and one is Staph aureus. The specific toxin which produces toxic shock syndrome in Staph aureus is enterotoxin F. Okay, so this is enterotoxin F. The other enterotoxins in Staph aureus lead to normal food poisoning that we have studied, right? 0 to 6 hours preformed toxin. That's Staph aureus, other enterotoxin. But when it comes to F, Staph, that is what is responsible for toxic shock syndrome. Whereas in strep pyogenes, you have something called as pyrogenic exotoxin. So the name tells you pyrogenic matlab fever. So this is pyrogenic exotoxin. People call it as SPE, streptococcal pyrogenic exotoxin. So these are the two toxins which cause toxic shock syndrome, they produce super antigen. Another point that you can remember here is they'll give you a buzzword in toxic shock syndrome as some sort of retained foreign body, either a retained tampon, yeah, a female used tampon for menstrual cycle and forgot it, or a retained nasal gauze piece. Somebody had epistaxis, put a nasal gauze piece and forgot it. So that gives a bed for these spores to form and the toxin to be formed. So that history followed by fever, shock is when you think of toxic shock syndrome, right? So looks like a very busy slide, but we've just laid the foundation for all of the bacteria and finished the toxins here. So it's a very, very important page. And now when you go to individual bacteria, now I'm not going to talk about all of these. Okay. So one more thing here about bacterial genetics is the only genetics I'm going to teach you. So you know how we have conjugation, transformation, transduction, 12 standard stuff. Conjugation was when there was a plasmid that could be transferred, right? Transformation, I will talk about. Transduction is when we have bacteriophages. So now bacteriophages could be lytic or lysogenic. It's these lysogenic ones which are going to integrate with the genome and they can give rise to toxins. So what are the toxins coded by it? This has never been asked, so there's a little extra party question. So you want to remember A, B, C, D, E. So A, B, C, D, S is what you can remember. Everything will come very naturally to you except A. A is not anthrax, right? So A is what is S pyogenes, right? So A for group A. So this is your group A beta hemolytic strep. So that's why A. Then everything else which you can think of. So B is botulinum toxin. C is cholera. So I'm going to write cot because cot is zot. D is diphtheria. S is Shiga-like toxin, right? So these are the ones which are coded by lysogenic phage. So now talking about gram-positive bacteria. So first what I want to discuss is the big category of cocci. All cocci are gram-positive except manvi, right? So Moraxella, Giardia and Veillonella. Everything else comes here. So we're going to target that first. So all cocci. So first step is to check for catalase, whether it is catalase positive or negative. So catalase positive is staph, right? You can see how staph here is arranged in clusters, whereas catalase negative is streptococcus. Strepto means chains, right? So this is how it's arranged in chains. This is the most basic thing. Now, while I am talking about catalase, let's finish that first and then we'll come into staph strep. Okay, so let's talk about catalase test. So this is an image which is showing you catalase. So what we do here is we take a drop of H2O2. That's what I've taken, and then we put our bacteria. So if the bacteria doesn't have catalase, H2O2 remains as it is. But if the bacteria has catalase, it's going to break it down into oxygen and water. So you can see how there is bubbling because of formation of oxygen. So this is how you can interpret these slides. It makes for a very good question. So now what are the organisms which are catalase positive is what we have to remember here. Now there are many catalase positive organisms, but whatever I am teaching you are the most important ones. So you remember the mnemonic space here. From S, obviously we are talking about staph, right? So we'll just write staph aureus, but you remember all staph are catalase positive. And from S itself, we remember Serratia. From P, you remember Pseudomonas. Okay. Then the next three are going to be fungi. So which fungus do you know from A? Only one you would know, which is Aspergillus. Tell me two fungi you know from C. You would only know Cryptococcus and Candida. So three fungi next on the list. And E, this is where they'll trick you. They'll give you Enterococcus in the option. But Enterococcus, remember, is a type of Streptococcus. So can it be catalase positive? No, that was catalase negative to begin with. So it can never be Enterococcus. That will be your option because they know space. Okay, so you know that, okay, E must be there and they'll give you something random which is not on this list. But what you have to remember is it's an Enterobacter, and that's the whole principle of how you study. What you are studying should be so strong that you can't get confused with Enterobacter and Enterococci. So study less but master this. The problem is students will memorize a whole 100-page list of catalase positive. I'm exaggerating, but they'll remember this huge list of catalase positive organisms and in the end get confused between Enterobacter and Enterococcus. So what use is that? So do little but master it. You can't go wrong here. That's what is the moral of the story. So catalase positive, E for enterobacter, which is catalase positive. Now, what more can I take out of this list? Staph aureus, serratia, and Pseudomonas. What do they have in common? All three of these produce a pigment, and they ask you the color. So first of all three of them produces a pigment. What color is Staph aureus pigment? So uske naam mein hai AU. AU means gold. So this is what produces a golden yellow or a golden color pigment. Gold is also yellow, right? So golden. Serratia raw produces a red pigment. What is the problem with a red pigment now? The problem with red pigment is that we'll think it is blood. Yeah, so that's what you want to remember, that serratia, because of its red pigment, is confused. There are two syndromes associated with this. One is called as red diaper syndrome and one is called as pseudo hemopsis. So both of these actually, tell you that because of its red pigment, people either think that the patient is having hemopsis or the patient is having hematuria, right? So that's what you want to remember about serratia. Something unique, we can link biochemistry with micro here. Red diaper, these red urine crystals are also something that you can see in Lesch-Nyhan syndrome. Okay, the spelling might be wrong. I think it's fine. So this is the Lesch-Nyhan syndrome where you also have red diaper, okay, where you have these reddish crystals, okay. So this is what was your HGPRT deficiency. Salvage pathway is deficient here, okay. So this is what you can remember as a side note. Going back, so you have golden and you have red, and Pseudomonas can produce anything in the range of blue-green shade, okay. So these are the three pigments you want to remember. That's why if that's your blue nail syndrome, if the nail has become blue, what is the cause? Blue can only be formed by Pseudomonas. So this is what leads to blue nail syndrome, right? So this is our list. We have done all except kind of a question. We have done pigment question, and now which disease will have preferentially catalase positive infection? So that is something which is very, very important. So you have chronic granulomatous disorder. So CGD is what you remember. Chronic granulomatous disorder is where you don't have NADPH oxidase. So when we don't have NADPH oxidase, you can't have the respiratory burst mechanism. And then when you have this catalase, along with water and oxygen, you also have free radical formation. So when these catalase positive organisms make the free radicals, our body can't fight because we don't have NADPH oxidase or the respiratory burst mechanism. So that's the whole concept here. So you have recurrent infections from catalase positive organism, and they will give you investigation of choice. So you want to remember again 2 3-letter words. So we have NBT test and DHR, out of which DHR is preferred. So NBT is nitro-blue tetrazine, whereas DHR is dihydrorhodamine. No need to remember the full forms, just remember NBT, DHR for chronic granulomatous disease, recurrent catalase positive organisms. And I also told you that recurrent catalase positive infections can also be seen and cold abscesses we had seen in FATE. Remember FATE? Which immunocompromised disease had FATE as a mnemonic? So that one was Jobs syndrome, right? Hyper IgE. So both of these conditions actually will have catalase positive infections. The more characteristic is chronic granulomatous disease. So this is the detour we took, and we covered a lot of ground. Going back to where we came from, which was catalase. So catalase positive is staph, right? Now further I have to see coagulase. If coagulase is also positive, it has to be the OG, most virulent, staph aureus, right? So this is where we have staph aureus. When we go to coagulase negative, this is what we refer to as cons. Coagulase negative staph. There are two cons you need to be aware about. I checked the novobiocin sensitivity. If the novobiocin sensitivity is not there, can I say this is no-go? Novobiocin is not there. No-go. It's a no-go. So this is what is S-sapro saprophyticus. So this is S. saprophyticus, whereas novobiocin sensitive is S. epidermidis. Okay, so what you want to remember is saprophyticus no go. It's novobiocin resistant and it doesn't even allow urine to go. Urine is a no go. So this is what causes UTI. This causes UTI in sexually active females. So this is the second most common cause of UTI in sexually active females. The most common cause always remains E. coli, right, for UTI. So this is what is the second most common cause of UTI in sexually active females. Sir, say sir, saprophyticus, remember no go, you remember everything else. S. epidermidis, as the name suggests, is a commensal of the skin, right? So whenever we insert any prosthetic device like a prosthetic heart device, pacemaker, central line, in prosthetics, remember the most common cause of infection are corns, particularly S. epidermidis. So you remember they're in the skin only. Whenever I insert something, they go along. Our own body bacteria attacking us itself. So this is where they are coning us. Okay, so this is how you remember that cones, prosthetic device, epidermidis. Fine. So with this we finish off staphylococcus. Going into streptococcus now. So when we are talking about strep, now we divide it on the basis of hemolysis. How do they appear on a blood agar? Alpha hemolytic strep will appear green because they cause partial hemolysis. Beta cause complete hemolysis, so they appear clear, whereas gamma shows no hemolysis. Blood will remain as it is, but they can also grow in bile, okay? So this is about alpha, beta, gamma. That's how they are divided. Going first into alpha hemolytic strep. So here the buzzwords will be optochin sensitivity and bile solubility. When this is negative, this is S. viridans. Streptococcus viridans. S. viridans has further, small species within it that you would study as S. mutans, S. mitis, S. sanguines. Okay, so these are the ones that we remember here. So S. viridans, remember, act as commensals of the oral mucosa, right? So they are present in the oral cavity, and that's why if they ever say that somebody had endocarditis with history of some sort of dental maneuver or manipulation, the cause is S. viridans. S. viridans causes community acquired infective endocarditis, subacute endocarditis, and history of oral manipulation is important. So remember, these are commensals of the mouth, S. viridans. Then when they give you that all of this is positive, this is a bacteria which is everything. You know how some people get everything in life, right? So this is in bacteria's world, that is S. pneumoniae, who has optochin sensitivity also, bile solubility also, thousand other things which I'll tell you. Who is that? That's S. pneumoniae. So S. pneumoniae gets everything. If you don't know the answer, if they ask, does it have this? Answer is S. pneumoniae, has everything. Okay, so let's go into S. pneumoniae's world and now understand a few questions. So this is what S. pneumoniae looks like. They are described as these lanceolate diplococci, flame-shaped lanceolate diplococci. You can see they are arranged in pairs, and you can see how they have a polysaccharide capsule which is swelling up. So when you add this antisera and they swell up, this is what is called as the Quellung reaction. So this Quellung reaction is what is shown in the picture, and if you see their colonies on blood agar, this is what looks like carom coin. So this is what they call as either Drotzman or carom coin colonies. Okay, so that's another name, Drotzman or carom coin, lanceolate diplococci, Quellung reaction, and the fact that they have polysaccharide capsule. Not just a polysaccharide capsule, does this also have a vaccine, a subunit vaccine from polysaccharide capsule? Answer is yes, it does. So what are all the infections which have a polysaccharide capsule and a vaccine against them? So this is a very important list that we remember as SHIN. So one is obviously what we are discussing, that is S. pneumoniae. Second is H. influenzae. And third is N. Neisseria. Now very important, which Neisseria? Not gonorrhea. Gonorrhea doesn't have a capsule, doesn't have a vaccine. Imagine gonorrhea having a vaccine. World would be a much better place. It's not. So N meningitidis. So N meningitidis is what has a capsule and a vaccine. This is last year INICET question where they gave this list and asked all except question. So Shin is our answer. Now if you remember Shin, you also get a bunch of other questions free. So first question, who do I want to give this vaccine? For that, you want to understand this capsulated bacteria that are taken in the spleen. So they are coated first of all by what we remembered as opsonins. Remember C3b, IgG in general pathway study. They are the opsonins which coat them and take to spleen. So if somebody who has had a splenectomy, will these infections attack them? Absolutely. So these are the vaccines to be given in splenectomy patients. So you have Shin vaccines to be given to splenectomy patients to prevent these infections, right? So just to talk about it, pneumococcus has two vaccines. We have Pneumovax and Prevnar. In the recent times, they've been asking a lot of questions on vaccine strains. Okay, so they've gone much deeper into the vaccines. So that's why I'm covering this here. So we have Pneumovax and Prevnar. Pneumovax is the 23-valent vaccine where all the strains are covered, which is very good, but can be given in more than 2 years. Whereas Prevnar is 13-valent, which is in less than 2 years. So they can ask you these number of strains which are covered, okay? Whereas meningococcus has AC5W and there is a B strain. So what is the question usually asked is that is B strain covered in the vaccine? No, B is not covered, okay? The others are covered, right? So first thing, uniting Shin are the vaccines and we've talked a little bit about them. Another thing uniting Shin, I mark that in green, is transformation. Remember talking about bacterial genetics. So transformation is something I don't know if you remember, but we studied this in school called Griffith experiment. So it's nothing much. This guy Griffith took a bunch of capsulated bacteria, pneumococcus, and they took naked pneumococcus and they ended up finding that the vaccine, the capsule could be transmitted from the capsulated bacteria to the naked bacteria, and that principle is called transformation. So all of these three show transformation because all of these three have the capsule. That's what we remember. And all three also have a common virulence factor called IgA protease. What was IgA? It was our mucosal barrier. Remember the J chain, it's a dimer. So this is what helps us in the mucosa. So that's why all three of these attack, you know, the respiratory tract. Pneumonia, H influenza and meningitis also come from the respiratory tract and then goes to the meninges. So this explains us a lot, right? So this is all about pneumococcus. Going back to beta hemolytic strep now. So now talking about beta hemolytic strep, as we said, this shows complete hemolysis. So here you need to know about two things. For beta hemolytic strep, what we do is the Lancefield grouping, which takes into account the C antigen, which is the carbohydrate, okay, in the cell wall. So Lancefield is for C. Here on this basis, we divide them into group A strep, group B strep. So further, we check the bacitracin sensitivity and PYR status. So obviously, who should have positive? Whoever is A, topper, will get everything. Yeah, that's our rule from RT also, renal tubular acidosis. So what you have to remember, positive matlab group A strep and negative matlab group B strep. So group A strep is who? That is S. pyogenes. Now further in S. pyogenes, what we do is the Griffith staging. Okay, so this Griffith staging is what is done for group A, which is S. pyogenes, which takes into account the M protein, right? So this is what takes into account M protein. Group B strep is S. agalacti. So agalacti group B is where you want to remember that I didn't give it anything. I didn't give it bacitracin, I didn't give it PYR, and B matlab babies. Now, if you tell babies that I will not give you this, the babies get angry, right? So I have to do something to compensate. So we need to take these babies to camp. What does this all mean? So now going back to this page, this is where you have camp test. There is this increased area arrowhead of hemolysis is called a camp positivity, and you remember babies. So group B strep needs to go on a camp. Why? B is babies, because group B strep is the most common cause of early onset neonatal sepsis or neonatal meningitis. Why is that so? Because group B strep, this is what comes from the vagina, right? So that's what you remember in preterm labor, in chorioamnionitis. Don't we give group B strep prophylaxis, it's this group B strep. Why do we give? Because now when the baby is born vaginally, they're going to get this first thing, and that's why universally there is a lot of controversy in what causes late onset neonatal sepsis. The most common agent varies, but it never varies for early onset, and that's why it's the most important question. The most common cause of early onset neonatal sepsis or neonatal meningitis is group B. That's why I told you B matlab babies. Okay, so B for babies, B for camp, because we refuse them the other two things. We also have to give them hippurate hydrolysis. So that's also positive for babies. One more extra point is they produce this red pigment on Islam media. Remember, the baby born is a Muslim baby. So Islam media. Fine. While we are doing this, just as a one-liner, what shows reverse camp test here is Clostridium perfringens. So just remember this, nothing else to it. Reverse camp matlab Clostridium perfringens, right? So now going on to gamma hemolytic strep, which don't show hemolysis and they grow in bile. Not just bile, look at these, they are so resistant, they grow in hypertonic saline, they grow in PYR. Who is this strong bacteria here? That is Enterococcus. Remember Enterococcus, catalase positive or negative? Negative, right? Strep. We are in strep right now. So Enterococcus is so resistant. Bile acylide agar. We add bile to it. So if they show you this black colored culture medium, that's bile acylide, and who grows? Enterococcus. And what is negative here is S. bovis. Okay, so S. bovis, remember, also called as S. gallolyticus. So this one species here is S. gallolyticus, and you want to remember BO is CO. This is what causes infective endocarditis in CA colon patients. So we're going to discuss this in a minute, but as of now, you remember BO is CO, and this is what is negative in gamma. So with this, we finish our gram-positive cocci, right? So I've condensed it a lot. I think micro is the subject that I've worked on, the maximum, and it's going to be very dense, but you'll find that almost everything gets covered very nicely. Okay, so you have to give it multiple reads. That's true for all of BTR 2.0. It's very condensed, but if you read it enough number of times, you're going to learn how it benefits you a lot. Okay, so this is what is catalase positive and negative cocci. So now while we are at it, let's just finish infective endocarditis. Let's just jump subjects and finish infective endocarditis, because most of the causes of infective endocarditis are going to be from the bacteria we have studied, which are strep and staph. So I want to finish this here so that you have context, okay? Before even I go into infective endocarditis, let's finish this image from Robbins, which has been asked, where they ask you to differentiate the different type of vegetations. So look at the pattern here. In the first one, you can see that the vegetations are arranged on the cusp, right, along the chorda tendineae. This is called the line of closure, right, where the cusp meets the chorda tendineae is the line of closure. So 1 and 3 is both places where you can see that the vegetations are on the line of closure. So the first one here is rheumatic heart disease, where you see them along the line of closure, and these are basically your fibrous, warty sort of vegetations. On the other hand, the third one is what you see in NBT. What is NBT? These are non-bacterial thrombotic endocarditis, also called as marantic endocarditis. Non-bacterial thrombotic. And what does this represent? This represents a paraneoplastic syndrome. Paraneoplastic syndrome to adenocarcinoma, right? Anything ajeeb or weird you hear, as a paraneoplastic syndrome, always think of adeno-CA. It's always adeno-CA which does all of this. So NBT, marantic are these red vegetations along the line of closure. Look at the second image. This is what is infective endocarditis. This is the only one which can destroy chorda tendineae. Look at this, it's completely torn. Not just that, this is also associated with what the image is showing, ring abscess. So ring abscess, destruction of the valve are all features that only infective endocarditis can do. And look at the fourth one, you can see that now the vegetations are on the under surface of the valve. So under surface matlab ulta the vegetations are present. So this is where you will remember, this is SLE, LSE. So this is what we call as Libman Sachs endocarditis, and LSE is seen in SLE. So when we do ulta of LSE, we get SLE. When we do ulta of vegetations, we get their valves. Okay, so that's how you're going to remember. Now let's go into the causes of infective endocarditis. Most common cause in IV drug abusers, hospital acquired, and acute infective endocarditis, remember, is Staph aureus, right? So this is the most dangerous one in most dangerous scenarios. What is unique about IV drug abusers? This is the only place where the most common valve is tricuspid. Everywhere else, what is it? It's always mitral, right? Mitral is the most common in rheumatic heart disease, most common in infective, everywhere. IV drug abuser is the only scenario where it's tricuspid, because how are you getting the IV drugs? You're getting it from the vein, right? So vein, where are the veins going to enter? They're going to enter the right atrium and meet the tricuspid valve, right? So that's what you want to remember, that this is where you have Staph aureus. Most common cause in community acquired infective endocarditis, and as I said, there'll be dental procedures. Sunte, what do we think of? What was the commensal in the mouth? The first thing in alpha we studied, S. viridans, right? So S. viridans is what is going to cause community acquired. Prosthetic valve, but less than 1 year, because after 1 year it's same as community. Yeah, so that's S. viridans. But for prosthetic, whenever we hear, we think of cons. Which cons? We already did this. S. epidermidis. So this is S. epidermidis. Ca colon, COSBO. So this is S. bovis or galolyticus, right, which was our gamma hemolytic step with negative. So that visual memory of that flow chart is very important. You will get there eventually if you don't get there right now. Okay, so this is what we need to know. Now while we are here, let's just finish the modified Duke's criteria. So this is the modified Duke's criteria for infective endocarditis, and this is the 2023 version here, right? It was updated in 2023, and the changes here, this is the major criteria that I'm showing you. The changes here are highlighted in bold. Okay, so we can know what got changed also. So firstly, let's get a macro view here. Major criteria are 3. One is microbiological evidence of the organism, which can either be via culture or a lab test. So that's the first thing. Second is proof of the vegetation in the heart, which can either be via echo. They've also added CT imaging now, and they've also added FDG PET imaging into this now. Previously, it was only echocardiography. And the third is direct inspection. So now you have done direct inspection during heart surgery, right? So this is what is essentially the thing. So mainly 2 things only: microbiological evidence of the bacteria and evidence of the heart valve getting involved, right? So that's infective endocarditis. Prove infection, prove endocarditis, right? So how do you prove blood culture? So this is important. So I need 2 or more positive. So this is what is important, that we need the result to be positive in 2 or more separate blood cultures. Previously, the criteria used to be, or still the criteria for taking the sample. So how many minimum samples do I need to take? Minimum of 3 samples, 30 minutes apart at least, and from different sites. So different sites, 30 minutes apart, 3 samples is what is important, out of which 1 has to be directly from the valve, right? Out of which 1 should be directly from the valve is what is important, out of which 1 has to be a central sample. So this is the criteria. This was tested as to how do you take the blood sample, out of which 2 or more should be positive, then which rarely cause should be isolated from 3 or more. So that's fine. Then when we talk about lab test, positive PCR for Coxiella bartonella or Whipple's, Coxiella is the only one which is the exception, which can be isolated from a single blood culture. Okay, I'll give you a trick to this, but right now remember, Coxiella is the only one jahan pe we have said that even 1 is okay. Echo, CT or PET CT showing valvular damage, right? So this is what the criteria is in its essence. Then when we talk about the minor criteria, we study a lot of things, but these 3 images become very important. So what you see here in the pulp of the digits are what we call as oscillor nodes, right? So these are oscillor nodes. You can get image-based questions, whereas in the palm, these are Janeway lesions, which are painless. And what you see here in the eye, we'll also study this in opthal. These are the Roth spots. So here you want to remember both which have an O, Osler and Roth. What are they? They represent the immunological phenomenon. Alright, so these are immunological phenomenon, whereas Janway lesion, Janway, represent the vascular phenomenon, right? So you have vascular emboli in a lot of places. Janeway is one of them. There's Osler and Roth along with glomerulonephritis and many other things represent the immunological phenomenon, right? So this is what is important. Osler nodes are tender, Janeway are painless. So now talking about gram-positive bacilli. So when we say bacilli, first things we want to talk about aerobic, right? So there are 4 main bacteria that we are going to now talk about in aerobic gram-positive bacillus. So look at the first one. So this is where we have these tables, okay? You have to see the features and tell me which bacteria we're talking about. So this is the only bacteria which has a polypeptide capsule. We saw a bunch of polysaccharide capsule. This is the only one with a polypeptide capsule, and we are talking about bacillus. Okay, so bacillus anthrax here particularly. So there are 2 main bacilli, Bacillus anthrax and Bacillus cereus. The first few points I'm talking about anthrax, okay? So it has a polypeptide capsule, important. Remember 2 M names. One is the amphibian test and second are the medusa head colonies. Both are for Bacillus anthrax. It is a class A bioterrorism agent. You know, anything which is so dangerous, right? Like anthrax has to be class A. Ring precipitate test or Ascoli's test. So ring precipitation test or Ascoli test are for bacillus, okay? Then when you do a stab, so whenever we are growing something on a test tube, you have to do what is called as a stab culture, right? So whenever you do a stab culture, you know that it's aerobic. So how is the bacillus gonna grow? It's gonna grow on the surface. So this is where you have what is called as inverted fir tree. Whereas if you have an anaerobic bacteria, let's say Clostridium, it's going to grow like a real fir tree where it grows, you know, more on the bottom and then less on the top, right? So that's very logical. Bacillus, because it's aerobic, has an inverted fir tree appearance. Now talking about culture medium. So here, first we discuss, then we write. So when we talk about Bacillus cereus, I am sure you know one thing, it causes food poisoning, early onset as well as late, right? So there's an early emetic form, late diarrheogenic form. So that is what causes food poisoning, and the buzzword for that would be Chinese food. So they'll write Chinese food and then you had food poisoning. How will you reheat Chinese food and then you will have food poisoning? You're going to reheat in a plate, right? So you're going to remember that plate will make you think of Bacillus cereus. Whereas when you talk about Bacillus anthrax, one, it has a cutaneous form where you have eschar, yes. Second, it has a mediastinal hemorrhage. It has a pulmonary form where you have mediastinal hemorrhage. So that is what you need to remember, that my pulmonary anthrax will remind you of hemorrhagic mediastinitis, will remind you of Bacillus anthrax. But is word so straight that whatever you remember is correct? It's always opposite. So this is what we call as cross mnemonic, where plet reminds you of B cereus, but it is the culture medium for B anthracis. Whereas my pulmonary anthrax will remind you of anthrax, but it is the culture medium of Bacillus cereus. So this is the first of many cross mnemonics, okay? So that's how we remember. So simultaneously we remember a lot of points. We said B cereus will cause Chinese food related food poisoning, has 2 phases. Anthrax causes hemorrhagic mediastinitis, which is also a repeat question, right? So this is what is about bacillus. Going on to the next bacteria, gram positive aerobic. Here you have the letter L. It is growing in cold temperature. This is what we call as cold enrichment. It shows tumbling motility, not just tumbling, it can also show differential motility. Differential motility means motility at different temperatures will be different. It's non-motile at one temperature, motile at other. So temperatures are not very important. You can also remember that. But which 2 bacteria show differential? So one is the one we're talking about. So that is Listeria, and the other one is Yersinia. So you want to remember that both Listeria and Yersinia show us differential motility. So that's about one other question. So cold tumbling motility, Palcum agar. So everything L is listeria. Another important point, party question is if they tell you actin polymerization and rocket tail, the movement is by rocket tails, and this is what is called as jet actin motility, right? So this jet actin motility is seen in listeria. Remember, it's the only gram positive to have endotoxin. With that only, another extra edge point, endo Anton. So this shows Anton test, and the drug of choice here is ampicillin. So this is where the drug of choice is ampicillin. Listeria tends to cause meningitis or sepsis in extremes of ages. So this is where it causes meningitis either in infants or in elderly, right? So extremes of ages, we always add ampicillin in their prophylactic meningitis treatment. So usually for everybody we give vancomycin plus ceftriaxone, right? So vancomycin, which will target gram positive, plus ceftriaxone, which will target gram negative, is what is used for empirical treatment of meningitis, whereas we add ampicillin in extremes of ages. So this is what we need to remember here. Talking about the next bacteria, we are talking about Mycobacterium TB. Yeah, so Mycobacterium TB entirely we are going to be talking about when we go to PSM, but just a little bit core micro I want to talk here. So there are three culture media. Traditionally, we use LJ media. So this is what is the green colored LJ media, and they ask you why is it green? It is because of the presence of malachite green, and that is what gives it the green color, and that is what makes it selective. Automated media now we have, which are called Middlebrook and MGIT. MGIT are Mycobacterium growth indicator tubes, right? So they indicate the tubes by means of various methods. Okay, so that's MGIT. So this is culture. Virulence factors, two main virulence factors. One is the cord factor, which is unique, and second is LAM. So LAM, liposo-arabinomannan, is what can also be detected in the urine of patients, and this is the virulence factor which inhibits phagolysosome, right? So the mechanism is it inhibits phagolysosome formation. Auramine, rhodamine are the fluorescent stains for TB. Don't mix it with rhodanine. You might have this mistake in your book where it's written rhodanine. Rhodanine is for copper, okay? So some mistakes are there for a purpose that you remember. So rhodanine is for copper, whereas auramine, rhodamine are the fluorescent stains for TB. Another question, potential question, the sputum sample for tuberculosis. Remember, we want to concentrate it. So we use a method called Petrov's method, where you're going to put it with 4% sodium hydroxide. So this 4% NaOH is important. This is for concentration, okay? Now talking about the next bacteria here. So here you want to know about Corynebacterium diphtheria. So Corynebacterium diphtheria, you know the Chinese letter arrangement. Three special culture media. So you have potassium tellurite agar, where the colonies will be black. You have Loeffler serum slope, and you have MacLeod's agar. So these are the three culture media which you need to remember here. So now talking about few more points about diphtheria. So look at this Chinese letter arrangement. What is the stain that I'm showing you here? So this is what is the Albert stain. Now this Albert stain you need to remember is TIM. There are three components to this Albert stain. TIM. What is T? T is toluidine blue. You can see how the heads here are blue in color. You have I, which is iodine, and you have green body, which is malachite green. So these are the three components. In fact, if you just see, you can predict this, right? So why are the granules different in color? The granules are different in color because this is what has the diphtheria toxin. So this is why these granules are referred to as either metachromatic granules or volutin granules or Babes Ernst granules. So these are the granules which are going to produce the diphtheria toxin, right? So this is what produces the diphtheria toxin here. So metachromatic, volutin, Babes Ernst, right? So this is what you need to remember are the granules which stain with toluidine blue. Various stains for diphtheria. So you have Albert. There's also Ponder, Neeser, and Loeffler. So you can remember this as plan, right? So this can be remembered as plan, and out of this the best one is this Loeffler's methylene blue stain. Now Diphtheria is going to produce this membrane, right? So this is what we call as the pseudo membrane. Can this be easily removed? Remember, whenever this question is asked, nothing can be easily removed except candida. Candida is the only thing that we can wipe off. This will not be wiped off. It will bleed on removal. Apart from that, this girl here, very important, you can remember her clothes also, because this is so typical and probably the only girl who's had this. So this is what is called as bull's neck. So bull's neck is a feature of diphtheria where you have this swelling because of lymphadenitis. Remember, this bandhani pattern means diphtheria. All right. So this is all about diphtheria. So with this we finish off our gram-positive bacilli which are aerobic. Gram-positive bacilli which are anaerobic will include Clostridium. Now, out of all the ones which are aerobic that we studied, I want to write bacillus here. Why so? It's because there is something common to both of them, and that is that they produce spores. So, one thing here, that bacillus spores are non-bulging. Yeah, so their spores are not going to be bulging out of the body, but Clostridium spores are bulging. So you can remember there is a little cross mnemonic where B is not B. Yeah, so this is what we need to remember, and with this we venture into Clostridium now. So Clostridium botulinum, Clostridium tetani, already done. Let's look at the other two, which is Clostridium perfringens and Clostridium difficile. So first we talk about Clostridium perfringens, and the manifestation that I'm showing you here is gas gangrene, right? So we are seeing that there are these bullae here which are filled with air. So they'll either mention that there is crepitus which is present, and there is air in the subcutaneous plane which is present, right? So this is what you want to remember, that this is gas gangrene, and gas gangrene is caused by Clostridium perfringens. Clostridium perfringens, remember, produces most lethal toxin that there is, and that is what we call as alpha toxin. So this alpha toxin is actually a zinc phospholecithinase, all right? So this is actually a zinc phospholecithinase alpha. You know how the concept of alpha males nowadays is that they're also most lethal, most toxic. So that is what Clostridium perfringens is also saying, okay? So various words now, look at this. This is what is Naegler's test. Now, because perfringens has this toxin here, it can break down this culture medium which has egg in it. Egg is lecithin, right? So because of the toxin, this can be broken, and this is Clostridium perfringens, whereas mamuli, simple Clostridium, can't break it. So that is what is Naegler's test. Apart from that, 3 words for you. So target hemolysis shown by perfringens. It shows reverse camp. We already said that. It produces a stormy clot, and we use this Robertson's cooked meat broth, which is essentially for any anaerobic bacteria, right? Now let's talk a bit more about Clostridium in general. So overall, the spores are most commonly subterminal in all Clostridium, except 2 which have terminal spores. So tertium is tennis racket. So you can remember from the name, tertium is tennis racket. Tetany is drumstick. So tetany is drumstick. So terminal spores can either be drumstick or tennis racket. So you can remember this with TER. Stains for spores. So this is little extra, but you can find the letter sh. Letters sh here. Shaber, Schaefer and Ashby. So look out for sh for spores, right? Now let's remember something cool. See this picture. What does this remind you of? Alpha toxin, alpha male, right? So this is what is our proposed concept of alpha male, that alpha males will be like this, they'll kill people, they'll be most lethal, most toxic, and we sort of buy it, but we don't want to. So this is what is alpha toxin. So now when you see this, what do you see? That he's wearing this huge gun. Can I say it's almost like a capsule on him, on Ranbir Kapoor? So yeah, this is like a capsule on Ranbir Kapoor. If he wants to move around and fight now wearing this capsule, can he move around? He can't move around. So you want to remember that this toxic alpha male, who is Clostridium perfringens, has a capsule, and that's why it is immotile. So this will help you remember that this is the exception. This is not how good males are supposed to be. This is the exception. So you want to remember that Clostridium perfringens. Clostridium perfringens is the exception because it has a capsule. So the sentence is all Clostridium are non-capsulated except. Did you understand? It's a little complicated way to remember, but this is the only way to remember. So all Clostridium do not have a capsule. Only perfringens has a capsule, and then there's this baby Clostridium, which is Butyricum, which also has, which we don't care about. So our perfringens has a capsule. We said perfringens now can't move, so that means others can move. So I can write all Clostridium are motile except. Yeah, so this is the way to remember alpha male, toxic, and everything comes together. So all are motile except perfringens, which can't move because of its thick capsule, and there's this baby tetani vi, which also can't move. So this is all about our Clostridium here. Going on to Clostridium difficile. So this is where they'll give you this typical medicine history, that there is history of antibiotic usage followed by diarrhea. So when you have diarrhea in an admitted patient, what is it? This is Clostridium difficile induced pseudomembranous enterocolitis. So this is pseudomembranous enterocolitis. This is where you have two toxins, vowels stick together. Remember, A, E, I, O, U, vowels stick together. So toxin A is enterotoxin, whereas toxin B is cytotoxin. Okay, so remember this, that this is not where A and B, B matlab binding, A matlab action, that doesn't apply here. So this is where you have to remember A is what is causing the diarrhea and B is what is causing the damage to the cells, because of which you have cellular damage, you have membrane formation. So this is why you have pseudomembranes. And when we look at a cellular level, look at this. This is the degree of inflammation. So look at this volcano of inflammation resulting in the formation of these membranes. So this is what is called as the volcano sign, resulting in the formation of pseudomembranes. When you look at the CT, you can see how the entire bowel is thickened. It is thickened like an accordion. So this is likened to this harmonium-like instrument called accordion, where you have these things that you play a harmonium with. So that is what they thought. So this is the colon, and this white thing is the oral contrast we have given. So you can appreciate how thick the bowel wall is. Okay, so this is what is called as the accordion sign. Fine. So we have done the RAD path here. We are going back to the microbiology. Investigation of choice is to demonstrate the toxin. So this is toxin demonstration. Now this can be done either by PCR or ELISA. This was asked as an AIMS question once as to which is better. This is a little controversial, given differently, but PCR is a better answer here. Okay, so investigation of choice is to see that. Drug of choice, very, very important, is vancomycin. So what kind of vancomycin do we give? We give oral vancomycin, right? So vancomycin normally everywhere is given systemically because it has no absorption. But here, I actually want there to be no absorption. I want its action on the bowel, and that's why we are giving oral vancomycin. And you have fidaxomicin. So fidaxomicin and oral vancomycin are your two drugs that we give here. New drug, bezilotoxumab. No need to remember. It has tox in it, indicating toxin. It acts on the toxin, right? So that will tell you the answer. So this is all about Clostridium in general. A lot of ground covered. Going back to the final thing in gram-positive is gram-positive branching filaments, right? So this is where you have nocardia and actinomyces. Nocardia is aerobic, whereas actinomyces is anaerobic. If I ask you what about acid fast, again you'll say aerobic is acid fast. Remember nocardia, legionella, 1% H2SO4, whereas actinomyces is anaerobic, acid fast negative. If you look at the name, you will know. No. Aerobic, no. Acid fast, no. So this is how we can go about this. So now what you want to remember, nocardia is an infection which can mimic tuberculosis. So this is what can mimic tuberculosis, and This is something that is frequently seen in immunocompromised patients. Particularly, we see this, in renal transplant. Post-transplant immunocompromised patients can get nocardia. It involves the lungs, has cavitation, can involve the brain, can have brain abscesses. So this is what nocardia does. Talking about actinomyces. So actinomyces, remember, is something that can cause actinomycetoma. We will study when we go to fungus that there is Madura foot. One of the DDs, there is actinomycetoma, which can also produce those discharging sinuses, but the color there is yellow. So if they give you yellow granules or pale granules, they're talking about actinomyces, but if they talk about black granules, we're talking about Madura mycosis. A little racist mnemonic, but you can remember actinomyces. If you ask a South Indian to say actinomyces, they'll say actinomyces. Okay, I'm not proud of this mnemonic, I'm sorry, but you can remember actinomyces, right? So actinomyces produces yellow granules. So that's the first thing. That's how we distinguish actinomycetoma. The second thing it causes is dental infections. It can also cause chronic osteomyelitis of the mandible. And the third thing is it can cause PID, pelvic inflammatory disease, particularly in patients who have intrauterine devices. Okay, so in intrauterine devices, you can have, and there you actually see, these filamentous organisms forming this cotton ball kind of appearance, right? So this is what you need to know. Apart from that, the colonies that you see look like molar tooth. So you have molar tooth colonies for actinomyces. So many questions: mandible, actinomycetoma, PID in IUDs, molar tooth, right? So this is what we need to remember about these. As far as the treatment is concerned, we have studied this in pharma, but just to recapitulate, treatment for nocardia was TMP SMX, cotrimoxazole. Whereas for actinomycetoma, it is still receptive to penicillin, right? So this is still penicillin. You can remember SNAP here. Nocardia is sulfomethoxazole trimethoprim and actino is penicillin, right? So finally, we finish all gram positive bacteria. Very heavy slide, but worth it once you revise it well. All right. So now we go on to our gram negative bacteria classification. So now talking about gram negative bacteria, here the main category is bacilli, right? We already know the three Manvi exceptions, out of which what is most important for us to know in detail is Neisseria. So let's just first finish the diplococci here, which is Neisseria. So they are both aerobic, Neisseria meningitidis and gonorrhea. So when we talk about the difference between them, remember who has a capsule is the one that can utilize maltose. The answer for both of them is M for maltose, M for meningitidis. So Neisseria meningitidis is what is a yes for capsule, as we have already studied, and a yes for maltose, whereas remember N gonorrhea does not have a capsule and can neither utilize maltose. All right, then let's do the detail. So this is what gonorrhea image you can get, right? So can you see how they are within the WBCs and they are intracellular diplococci? So gonorrhea, remember, they will describe that somebody has cervicitis or urethritis, and when the discharge was done on a gram stain, you can see these pink gram negative intracellular gram negative diplococci, whereas their best friend, gonorrhea's best friend, is Candida, which will not show you any gram staining. Chlamydia, Mycoplasma, Rickettsia. Three bacteria which don't show gram stain. So that's where they'll tell only WBCs. So that's how you can distinguish gonorrhea versus chlamydia. But remember, there is no need to distinguish because we always treat them together, right? We always give azithral plus cefixime. Azithral is going to target chlamydia, cefixime is going to target gonorrhea, right? So we always treat them together, but this is just on a side note. This image-based question can come. Meningitidis, remember, causes meningitis, and they'll give you something here where the patient has a petechial rash. So when they give petechial rash with meningitis and they say that the patient went into a shock, Why did the patient go into a shock? Because the patient has adrenal hemorrhage. Look at this gross specimen. The patient has adrenal hemorrhage, because of which adrenal insufficiency, patient goes into shock. What is this syndrome called? This is what we refer to. Very, very important question is Waterhouse Friderichsen syndrome. So in fact, what you want to remember is, as soon as you hear meningitis with a petechial rash, shock matlab water. So that's how you're going to remember Waterhouse Friderichsen syndrome. On the other hand, when we talk about gonorrhea and chlamydia, as we discussed, lead to PID, pelvic inflammatory disease. Pelvic inflammatory disease along with these liver adhesions. So when you have this perihepatitis, right? So when you have this perihepatitis, which are your violin string adhesions, right? So this is something which is very unique. You have liver involvement because of pelvic inflammatory disease. So we call this syndrome as Fitz-Curtis-U syndrome. How I remember this is, it is named after 3 boys, Fitz, Curtis and U. So when you have three boys in your life, you're going to have PID, right? So that's how you can remember Fitz-Curtis-U syndrome. So 2 syndromes with Neisseria, 2 big names, very, very important syndromes. Just to finish it off, the transport medium for Neisseria is what is Stewart and Amy's medium. Stewart and Amy, both characters in Big Bang Theory, if you know. So in fact, Stewart also looked like somebody who had gonorrhea. So you can remember Stewart Amy's is the transport medium, whereas culture medium is Thayer Martin. So Thayer Martin is the culture medium, and just little extra here, in Thayer Martin, why we make it selective? It has vancomycin. You remember VCN. It has vancomycin, it has colistin, and it has nystatin. So vancomycin will inhibit all gram-positive cocci, colistin will inhibit all gram-negative bacilli, and nystatin will inhibit fungi. So I killed gram-positive cocci, I killed gram-negative bacilli, and I killed fungi. So all that is left is gram-negative cocci, right? So that's how selective media work. They inhibit the others, they are selective for one bacteria. So that's Thayer Martin. So this finishes off Neisseria for us. Now let's go into the other small category of comma-shaped gram-negative organisms. All of these are oxidase positive. One buzzword for each. This one grows at a hot temperature, 42 degrees Celsius. This is Campylobacter. What was cold? That was Listeria. This is hot. So this is what we can remember as hot campfire. So this is Campylobacter. You can remember this is where we have Skyros medium, which is the selective medium. And Campylobacter is a risk factor for Guillain-Barré syndrome, Reiter syndrome, right? So this is what you need to remember. Reiter is triad of can't see, can't pee, can't climb a tree. Means conjunctivitis, urethritis, arthritis, right? This we'll study in dermat. The one which grows in alkaline medium here is Vibrio, and urease producing is H. pylori, right? So all of these are your curved rods which are oxidase positive. For H. pylori, we do this CLO test. So this can be asked as an image-based question. This is the CLO test. It essentially means Campylobacter-like organisms. You can see it's like Campylobacter, right? Talking about Vibrio now. So when we talk about Vibrio, the general rule is V. cholera, right? So Vibrio has a darting motility string test. They'll show you this image where somebody is picking up this from a slide and you see the string forming, okay? The transport medium is VR medium or Venkatraman Ramakrishnan medium. That's also the same classification, right? Venkatraman Ramakrishnan classification of cholera. And you have Carey Blair transport medium. The culture medium is TCBS, right? So this is where we'll discuss this in detail. Thiosulfate, citrate, bile salt and sucrose, right? So it is essentially based around sucrose. So even if you remember sucrose, it's good enough. Thiosulfate, citrate, bile salt, sucrose. Okay, so we'll talk about this once we do all culture media. Then we have V. parahemolyticus. It is capsulated, and that's how I remember that shellfish also has capsule, and this is also capsulated. So this is what is consumed, it causes food poisoning in people who consume shellfish. And who consume shellfish? It's Japanese or Oriental people who eat more shellfish. So you can remember it has all of these big Japanese names. So this Wagatsuma agar shows this Kanagawa phenomenon. So this is your NEET 2024 question. V. vulnificans is another vibrio which can cause sepsis, right? So this is all about vibrio. Now, when we talk about gram-negative bacilli, our whole point is going to be lactose fermenting versus non-lactose fermenting, and this is what is done on this McConkey agar. Okay, so McConkey agar has lactose, which will distinguish. So these pink ones are lactose fermenter, yellow is non-lactose fermenter, and I'm going to compare all of these important culture media for you in a while. So this is what is McConkey. So who are the lactose fermenting organisms? The one which are fast. So fast you want to remember E and K. So E. coli, K for Klebsiella, and with E only now you remember Enterobacter or cocci. Yes, this is Enterobacter. Enterococci was done with cocci, streptococci, right? So this is fast. Slow is So. So says Serratia. We studied Serratia as catalase positive, and says Citrobacter. So these are not very important ones, but these are slow. Then when we go to non-lactose fermenters, you have to check for oxidase. So if oxidase is a yes, this is where Pseudomonas comes in, and Pseudomonas's best friend is Burkholderia. Both of these friends go together in which disease? They go together in cystic fibrosis, right? So that's how you remember them. If oxidase is a no, now look at H2S. If it produces H2S, very important, we have Salmonella and we have Proteus. But if that's a no, we have Shigella and Yersinia. Shigella, Yersinia kind of sound similar, so they go together. We will talk about the important ones in a minute. Let's just finish Yersinia right here, right now. So Yersinia has two species. One is Yersinia pestis, which I'm sure you know as bubonic plague, rat flea. We have another Yersinia, which is Yersinia enterocolitica. So enterocolitica is the one which can mimic appendicitis, right? So Yersinia pestis, Yersinia enterocolitica mimics appendicitis, which we have also written in GI in the diarrhea table, if you remember. Okay, so this is the microbiology aspect. Now let's do the important ones clinically. Before I go anywhere else, let's just learn how to distinguish E. coli, Klebsiella, because both are fast lactose fermenters. So for them, there are these bunch of tests which are called as IMVIC tests. So this is what is IMVIC, indole, methylrad, VI and citrate. So remember as IMVIC, so E. coli will be positive in the first two because E and I, vowels stick together. So these two are positive, these two are negative. Whereas for Klebsiella, we are going to see negative, negative, positive, positive. Fine. So this is how we distinguish E. coli, Klebsiella, IMVIC out of the way. Now we go into Pseudomonas table. So this is a table dedicated to all things, all deadly things done by Pseudomonas. Very important. So Pseudomonas in immunocompromised patients is going to cause ecthema gangrenosum. Okay, so in immunocompromised patients, we are going to have these gangrenous lesions called as ecthema gangrenosum. Don't confuse this with ecthema contagiosum. That's why I've kept it here that this is different. It's not Pseudomonas. Ecthema contagiosum is actually a zoonosis caused by parapox virus. Okay, so this is seen in animal handlers. There's this finger pustular lesion. That's ecthema contagiosum, right? So that's different. Going on to malignant otitis externa, so that's a misnomer. They'll give you history of a diabetic patient with pus, granulation tissue coming from here. It's Pseudomonas. Burns, most common cause of infection, Pseudomonas. Cystic fibrosis, very important. In adults, most common is Pseudomonas, but in younger kids, Staph aureus is the most common cause of recurrent respiratory infections. Pseudomonas can be seen in patients who wear contact lenses. Two things here. Contact lens users are predisposed to Pseudomonas, that's one. Contact lens users, if they misuse contact lens, like bathing in dirty water, that can lead to a acanthamoeba infection, okay, because it's a free-living amoeba. So you want to remember, free-living amoeba, contact lens misuse is acanthamoeba. whereas Pseudomonas is another independent risk factor. Hot tub folliculitis, so jacuzzi history, hot tub folliculitis is Pseudomonas. Acute osteomyelitis in patients who get injured by a nail, yeah, not nail, the one that carpenter uses, okay, that, and drug abusers. So two acute osteomyelitis Pseudomonas causes. Everywhere else we have studied in ortho, any infection matlab staph aureus, whereas if it's sickle cell, then it's salmonella, and this is such a cliched question, like asked so many times, okay. So this is what we need to remember about Pseudomonas. Now let's go into E. coli table. So there are all of these E. coli species. EPEC matlab enteropathogenic E. coli. Enteropathogenic E. coli have P for pili as the virulence factor, and they cause P for pediatric diarrhea. So pediatric diarrhea, pili, enteropathogenic, and this has been asked as an image-based question. They lead to this effacement of the villi. So they give this sort of a fancy image where there was flattening of these villi. Okay, so whenever you see something like this, it's EPEC. Fine. ETEC we have already done is enterotoxicogenic E. coli. Two toxins, we have LT toxin and we have ST toxin. So LT is heat labile, whereas ST is heat stable toxin. LT we saw was increasing CAMP, this was increasing CGMP. So this is enterotoxicogenic E. coli, and here you want to remember this can cause traveler's diarrhea. Okay. IEC is entero-invasive E. coli. So these can invade into the mucosal cells and hence cause dysentery. And you can remember there is something called as a Sereny test here. This is a very invasive test where in a guinea pig's eye, if I put this entero-invasive E. coli, it will cause keratoconjunctivitis. Okay. So don't have to remember all this because you don't do all of this now, but you can just remember eye. Yes, what is eye? Eye is eye. So that's how you can remember Sereny test is for the eye. Wonderful mnemonic. Enterohemorrhagic E. coli. So enterohemorrhagic E. coli, we already know. What does this do? This has Shiga-like viroline toxin. What does it do? 60S ribosome inhibition. It will also cause bloody diarrhea, and there is one special species O157H7, which is the most common cause of hemolytic uremic syndrome. And you want to remember here that this is special. So I need to detect it specially. So for that we use this special McConkey where we also add sorbitol. So you can see this SORMAC written here. So sorbitol McConkey agar is what is used for detecting O157H7 because this can't. All other E. coli can ferment it. This special one can't ferment sorbitol. So that's how you can differentially detect. So moral of the story is sorbitol, 7, Shiga-like, 60S, right? So that's how you remember it. AEC is entero-aggregating E. coli. Suppose all of you aggregate to attend an offline class, right? Why do you aggregate for offline class even though you have online content? You aggregate because we are all persistent. That until I remember, I'm not going to give up. So this is what leads to persistent diarrhea. So persistent diarrhea, entero-aggregating, and you can also remember stacked brick. We are persistent, one brick after the other. That's aggregating bricks. So that's how you can remember that EAEC leads to stacked brick appearance on HEP2 cell line. So this is about E. coli. Now talking about Salmonella. So you know Salmonella typhi, typhoid. Here the characteristic feature is fever with bradycardia. You may see rose spots which come in the second or third week of the illness. For detection, you can remember BASU, right? This is pretty famous mnemonic and was asked in NEET 2024. So BASU, what you need to remember are the different methods of detection in different timelines. So in the first week, the best method is to do a blood culture. So that's for the first week. In the second week, we want to detect the antigen antibodies, which is via means of Vidal test. So Vidal test is the best for second week. You remember H antigen, O antigen. H was flagella, O was the endotoxin in the cell wall. S is stool culture. So in the third week, you want to do stool culture, and fourth week is where you want to do urine culture. Okay, so week wise diagnosis, you can just remember BASU and you will not forget this. Okay, you don't have to revisit it again. So this is all about our gram negative bacilli. The final thing left here is gram negative cocobacillus, which are your remaining ones, out of which H influenza we have already done partly with shin, right, that it has a polysaccharide capsule. We have pertussis, Pasturella, brucella and tularensis. All your mini bacteria come here. Let's talk little bit about H influenzae now. H influenzae, remember here that it does not grow in simple blood agar, it needs this chocolate agar. Now, chocolate agar is not literally chocolate. Okay, we're not putting dairy milk in this. Chocolate agar is where you are heating your blood to a higher temperature. So, usually around 70 degrees Celsius, the RBCs undergo lysis and they appear like a chocolate. So, that's one clarification. Why we do that is this releases two factors, factor V and factor 10. And these are the two factors that Haemophilus needs. So, factor V is NAD and factor 10 is hematin. So our Haemophilus influenza needs both of this, and that is why chocolate agar is the culture medium for H influenzae. Another phenomenon is satellitism. So this is also pretty similar. You know how hematin is there in blood, right? So that's factor 10. Now when you inoculate Staph aureus, we can see that H influenza grows like a satellite around it. Can you see? It's growing here. Why that is because this gives it the factor 5. Yeah, so this gives it the factor 5, whereas blood has factor 10. So around Staph aureus, can I say both factors are there and our H influenza can grow? Yes. So that's the principle of satellitism. So 2 points about H influenza. Now let's talk here. So this is what we call as Dine's phenomenon. Who shows this Dine's phenomenon? It is shown by Proteus. Okay, so Proteus was our gram negative bacillus that we didn't discuss. So Proteus shows Dine phenomenon, where two different species of Proteus, when you grow, are not going to join each other and they're going to have this thin line of separation, which is called Dine's phenomenon. Now with Proteus, we can do other points. Proteus, remember, is urease positive. S for staghorn calculus, staghorn or struvite calculus. This is what predisposes to struvite stones. We studied this in surgery. S for swarming motility. Proteus has swarming motility. So what you see here in the box are the other bacteria with swarming motility. Clostridium, Bacillus cereus and Proteus. Swarming motility can be inhibited if I use a very high concentration of agar, like 6% agar. So we can inhibit swarming. If you make it so thick, will the bacteria be able to move? No. So normal agar is at 2% agar where they can show swarming, but if you increase it to 6%, they'll not do swarming. Fine. Now, what is Dine staining? So Dine phenomenon is Proteus, but Dine staining, now remember, we are going into the next bacteria, that is Mycoplasma. So Mycoplasma, remember a story. You're very hungry. So what are you doing? You are doing dining. What are you eating? You're eating a fried egg. You are eating a fried egg. Once you eat a lot, what will your mom say? Your mom will say, Pani pilo. So PPLO, Pani pilo. You've eaten a lot, you've had a lot of pani. Now what do? You go for a walk. But it's very cold outside. So that's what is mycoplasma. But now when I say this story, you are like, wow, ma'am, such a good joke. And it's such a cute story. So these mycoplasmas are called as jokers of the bacteriology, or they are called as molecules. And why we are doing that is because they are the only organisms which do not have a cell wall. They are surviving without a cell wall. So are they going to do gram staining? No. How will they do gram staining if they don't have a cell wall? So no gram stain. Plus, what are beta lactams? Beta lactams as well as vancomycin. What do both of these do? They inhibit cell wall synthesis. Will they work in mycoplasma? Obviously not. It doesn't have a cell wall. So these are not effective, and that's why who is the drug of choice? The drug of choice are macrolides, azithromycin, erythromycin are the drug of choices. So say the story in your head one time. Dying, fried egg, eaten, pani pilo, walking, cold, joke, cute. Fine. So this has to come in this order. So dying, staining, fried egg colonies, two culture media, walking pneumonia because it's atypical. The patients are usually walking. They're good. All right. They're not very, very sick. Cold agglutinin because it produces IgM. Remember cold autoimmune hemolytic anemia? We did this in hemat, right? So that's IgM. So two cold agglutinin. One is mycoplasma. One is Epstein-Barr virus. So these two produce cold agglutinins is what we have learned there. So this is what we need to remember about mycoplasma. With this, we go into the next set of bacteria, which are your spirochetes. Spirochetes matlab spiral bacteria. So there are three main categories we want to discuss. What you will remember here is the type of coiling. So these images are important. So look at this first one when it is tightly coiled. T for tightly coiled, T for treponema. So these are your treponema which show tight coils. So T for tight coils, and they have corkscrew motility. So treponema, corkscrew motility. We have two silver impregnation stains. We have, because they are very thin, so we can impregnate, thicken them, right? So there is levaditi and there is fontana. Levaditi is the stain that is done for tissues, whereas fontana, fosse fluid. So this is what is done for CSF. So you just want to remember this special stain for syphilis, which is treponema pallidum. Then when you see a spirochete with loose coils, lashing motility, you want to think of Borrelia. So you'll remember a wrong spelling of Borrelia with two L's. L for loose coils, L for lashing motility. There are two Borrelia you want to remember. Borrelia burgdorferi causes Lyme's disease. Yeah. So Borrelia burgdorferi, Lyme disease. This is where they'll give you, somebody went on a trek, had a tick bite. Which tick? Hard tick. So hard tick is Exodus tick. And then they result in this rash. So this big target rash is what we learn as erythema migrans in Lyme's disease. We'll also discuss this in dermat. So this is what is erythema migrans, Lyme disease, Exodus tick bite. Fine. What you have to remember in Lyme's disease, the drug of choice for Lyme's disease is doxycycline. But sometimes you can have complicated Lyme's where it can lead to neurological features, meningitis, carditis. In that case, the drug of choice is cephalosporin, that is ceftriaxone. So this is what we need to remember about Lyme's. Borrelia recurrentis, as the name suggests, causes relapsing fever. So this is relapsing fever. You have epidemic relapsing fever, which is caused by loves. You want to remember this as love is epidemic. Everybody falls in love. Some people fall in love twice or thrice in the same day. So love is epidemic. So that's how we'll remember. And after you fall in love, even alpha males become very soft spoken. They're very, very soft spoken. So you'll remember love is epidemic, whereas after love is soft tick. Fine. So this is how we remember the vectors of relapsing fever. Now I've seen a lot of students confuse Borrelia with Bartonella. So I thought, let me just clear it right here, right now. Let's discuss Bartonella first. So Bartonella, three species. Bartonella bacilliformis is what causes Oroya fever, also called as Carrion's disease, okay? And you know what is the vector for this? Sandfly. So sandfly, remember in two contexts. One is obviously Kala Azar that we'll discuss. Second is Oroya's disease or Carrion's disease. So this is Bartonella bacilliformis. Bartonella Hensley, I'm sure you all remember from PATH we had discussed cat scratch, where what do we study? We study the stellate granulomas. So this is where you have stellate granulomas. Not just that, Bartonella Hensley also causes bacillary angiomatosis. This is what is typically seen in immunocompromised patients like HIV/AIDS. So bacillary angiomatosis, and there is one more disease called pileosis hepatis. Okay, so pileosis hepatis, cat scratch, bacillary angiomatosis is is Bartonella hensleyi and Bartonella quintana. Quintana kind of sounds like a trench. So this is what produces trench fever, and here also the vector is the louse. So remember, love can take you to a lot of highs, but it can also lead to a lot of lows, and the lowest of the lows is trench. Okay, so love is epidemic, but it is trench. Okay, it can lead to trench, if that makes sense. All right, so these are the three Bartonella: Bartonella bacilliformis, Hensley, and Quintana. So this Bartonella borrelia, please put it in your choti copy. Read it so many times that you don't have any confusion. Okay, talking about the third spirochete now, where the hallmark are hooks, and this is a question which has come in every single exam in the last few years. This is leptospirosis. So leptospirosis, you are going to have hooks on the two edges. Weil's disease. What is Weil's disease? It is icterohemorrhagic fever. Icterohemorrhagic fever, you have fever, jaundice. They'll give you conjunctival redness. So conjunctival injection or conjunctival redness. They'll describe somebody working in a field. Rat urine is your buzzword. Okay, so they'll give you something called as rat urine. Paddy field workers, right? So rice field has a lot of water involved, which can be mixed with rat urine. So all of these words will be described. Very, very important. EMGH culture medium is an independent question for leptospira, and this produces what is called as a Dinger ring. Okay, so all of these are so important. And one more neat question: leptospirosis is microscopic agglutination test. L and M go together. Remember, CAMP became ALP. L and M go together. So leptospira is microscopic agglutination test. What is cold agglutination? We just saw Epstein-Barr and mycoplasma. With this, we go on to the next one. So, standard agglutination test is what is seen in brucella. So, brucellosis is standard agglutination test. You will see this as a zoonosis. So, this is something that is seen in animal handlers. There is Castaneda's biphasic agar, and you can remember Rose Bengal test here. Okay, so Rose Bengal, Castaneda's biphasic agar, and standard, three buzzwords for brucella. So this is what is a very high, very confusing slide here. So revise this multiple times. Now let's go and focus our attention on spirochetes. You can see how tightly coiled they are. And this technique here is our dark field microscopy. Dark field microscopy, as we discussed, I just got to change the condenser and nothing else. And we'll see this as a reflected light. So now do you get it? I am just seeing reflected. So if the slide is empty, it will be completely black. But if there is a bacteria, it will reflect the light and be seen without any stain. I can detect it. So this is what is using reflected light. So you can do dark field microscopy directly. You know, if there is an ulcer, you can take the ulcer sample and you will see the spirochetes, right? So now that we are discussing syphilis, let's just finish syphilis once and for all. So this is our summary slide of syphilis where we talk about all of the points. So syphilis begins as primary syphilis where you're going to have this ulcer. Okay, so this we'll discuss in dermat as well. This is what is primary syphilis, where you have this painless ulcer. Syphilis, painless. That's how we remember that this is your painless, hard, indurated chancre. So this is what is called as chancre. You may have lymph nodes here which are also going to be painless, described as these shorty, rubbery lymph nodes. Okay, so this is your primary syphilis. If this is left untreated, now this will become a disseminated infection where you have rash, mucocutaneous lesion, alopecia. So the next three images describe what we call as secondary systemic syphilis. First, let's talk about the syphilis rash. Syphilis rash is called as the great imitator, okay? It can have any form. What it doesn't have are vesicobullous lesions. So, vesicobullous lesions are something which are uncommon, and pruritus is uncommon in syphilis lesions. So these are not there. But mind you here, vesicobullous lesions can be seen in congenital syphilis. So here I'm not talking about congenital, I'm talking in general about secondary syphilis, where the lesions could assume any form, right? Like macule, papule, but they won't be vesicobullous and they'll not have pruritus. The characteristic lymph node for syphilis are called as epitrochlear around the elbow, and this is why there's something called as sailor's handshake. They shake hands like this and they feel whether there's syphilis or not. So this is a sailor's handshake, and that'll help you remember epitrochlear is the hallmark of secondary syphilis. Right. Now let's talk about, can the rash involve palms and soles? Yes, that's what we are seeing. So what are the rashes that can involve palms and soles? So that's what is a very, very useful mnemonic here called CARS. So CARS are the rashes that can involve the palm and the sole. CA is Coxsackie A. You can remember, when do we usually get a learner's permit? Learner's permit in our country comes at A16 for a CARS. Comes at 16 years for CARS. So remember Coxsackie A16. This is what causes hand, foot, mouth disease, herpangina. As the name suggests, this will have the involvement of palms and soles. R is very important. Rocky Mountain spotted fever will involve palms and soles, and as we are learning, secondary syphilis will involve palms and soles. So this is important. You can remember along with this only. What about A24 and enterovirus 70? So these two are causes of hemorrhagic conjunctivitis. So you can remember this right here, right now, that A16 was hand, foot, mouth disease, whereas A24 is hemorrhagic conjunctivitis, right? So this is about the rash. Going on to mucus lesions. So there can be these ulcers in the mouth called as snail track ulcers. So snail track ulcers in the mouth, and you may have hair loss, which is called as moth-eaten alopecia. This was asked this year NEET exam. The same image came in the exam. So moth-eaten alopecia. So these are the features. In addition, we have these mucocutaneous lesions, which they confuse you with all the time. So in syphilis, you have LATA. You want to remember condyloma lata are seen at the mucocutaneous junctions. LATA 4-letter, flat 4-letter. So these are your flat lesions at the mucocutaneous junction seen in syphilis. Whereas what are condyloma acuminata? They are warts, right? So they are warts which we see in HPV, predominantly 6 and 11. So they'll tell you all of the following are seen in syphilis except, and they'll write condyloma acuminata. Acuminata is not seen in syphilis, it's seen in viral warts, whereas LATA, you can remember LATA has syphilis. Yeah, somebody called LATA has syphilis. So this is what you need to remember. Going on to, if this is left treated, there will be a latent syphilis phase followed by tertiary syphilis. So the next phase is tertiary syphilis. Tertiary means three main organs are affected. One is the skin, where you have gummas. So gummas are these nodulo-ulcerative lesions that you see in tertiary syphilis. You can have CVS involvement. CVS involvement will result in aortic dissection. Alright, so this is what leads to something called as cystic medial necrosis. So this cystic medial necrosis, something we see in Marfan's and other connective tissue disorder as well. So this is what affects, and this is called, described as this tree bark appearance, okay, tree bark aortitis. So that's a feature of tertiary syphilis. You may have neurosyphilis. So in neurosyphilis, what you need to remember is what we have studied in neurointegrated, tabes dorsalis. So tabes dorsalis, where dorsal columns are involved along with lancinating pain. Do you remember the nerve roots are involved? So you can have loss of deep tendon reflexes completely. There can be neuropathic pain, and you can also have Argyll-Robertson pupil. This pupil tells us everything we need to know. ARP. ARP matlab accommodation reflex present, whereas light reflex absent. accommodation reflex present. So these are all the markers here in tertiary syphilis. Two questions about the diagnosis. So the most specific test is FTA-ABS. Is a little confusing, but just want to tell you that these troponymal antibody, wherever they write fluorescent troponymal antibody, these are specific. But VDRL, RPR are not specific. So that's the only thing you want to remember. But what is the best to monitor response is VDRL, because this is what declines with treatment, whereas FTABS once positive shall always remain positive. Same with congenital syphilis. The best test to detect congenital syphilis is VDRL, where if the baby has 4x the titer of the mother, this is what is the criteria for congenital syphilis. So this is what you need to know. So essentially what they can ask you, the answer will be VDRL. Yeah. So this is all about the diagnosis. Treatment is penicillin. So actinomyces and syphilis are the only two infections where penicillin is still effective, right? So that's what we need to remember. So this is your summary slide on all culture media now. So let's look at this. So when we talk about mannitol, salt and ludlam agar, these are two culture media selective for Staph aureus. Pike is the transport media and crystal violet is the culture media for S. pyogenes, right? So this is for group A strep, S. pyogenes. Bile esculide agar, as we saw, is for enterococcus, most resistant, can grow in 6.5% NaCl, can grow in bile. Bordet Gengu and Regan law are for pertussis, right? So the name Bordetella tell you, and pertussis, remember, will give you this appearance that is described as bisected pearl appearance. Okay, so very, very unique, and it will also give you this aluminium paint appearance. So two named appearances for Bordetella. Very important infection, BCY. Another infection that leads to atypical pneumonia is Legionella. So Legionella culture media is BCY, buffered charcoal yeast agar. Because there is charcoal, if they show you this black culture plate, that's Legionella BCY. The colonies grow as these ground glass colonies here. Remember how we studied GGOs in COVID-19? So here you have ground glass colonies in micro. Specific thing about Legionella is via water transmission. So they'll give you some sort of history that the patient was on a cruise or something like that. Another infection which causes bradycardia like typhoid and hyponatremia. So this is important. This is Legionella. CLED and EMB both are for E. coli. So this is what we can use for UTI. But if I ask you which out of these is better, your answer will be CLED is better for UTI. Everywhere something is better because it is more selective. This is the only place where this is better because this is less selective. In UTI, I don't just want to see E. coli. I want to find out any other cause that there is. So this can pick up other causes also. So this allows the growth of gram-positive cocci. This allows the growth of candida as well. So we can pick out other causes of UTI in this. So this is what is important, that's why this is better. And we saw, right, as saprophyticus is the most common cause of UTI in sexually active females. While we are talking about UTI, let's just do this. This was asked in NEET 2024. So this is the CAS criteria which says that for E. coli to be the cause of UTI, we need how many? We need 10 raised to 5 colony forming units of E. coli. 10 raised to 5 colony forming units per ml of E. coli. The exception, this is what was asked. So you can remember here, suprapubic aspirate. If you're doing a direct SPC aspirate, we don't need to fulfill this. Gram positive and candida, the other two, which we are allowing in the CLED media, we don't need to fulfill this. And if the patient has already been started on antibiotics, obviously we don't need to fulfill. So you can remember SPAC as a mnemonic. Okay. Going back to the culture media, so Ashdown is something for Burkholderia. So this is a culture media for Burkholderia pseudomallei. This is an agent which is used for bioterrorism, and the more bioterrorism we do, we are just putting our globe, turning it into ash. Yes. So it's all gonna end with terrorism. So that's how you remember. B. Pseudomyelin used as bioterrorism, ash down. Selenite, tetrathionate, and DCA are used for Salmonella and Shigella. Okay, so these are the two bacteria where we use this. Now, to culture media where we are actually adding antibiotics. So cetrimide is Pseudomonas. Pseudomonas loves a challenge. It's like give something else and then I'll grow. So we are adding cetrimide and cefoxitin. Which bacteria did we see was growing when we were giving antibiotics? That was Clostridium difficile. So there I have to add cefoxitin here. So this is Clostridium difficile. Two culture media that you see here are what we use for drug sensitivity testing, right? So what you can see here is the Mueller Hinton agar, and this is what we call as the Kirby Bauer disk diffusion test. So Mueller-Hinton agar, Kirby-Bauer disk diffusion test. The concept here is that I've embedded the antibiotic onto these disks, and if the bacteria is sensitive, we'll see a clearance around it. So this is what tells us about drug sensitivity, but this is what is a qualitative test. It cannot estimate the quantity. Whereas if I want to see the quantity, which is called as MIC, MIC is the minimum inhibitory concentration at which the bacteria doesn't grow. So look at this. I have now put this on this paper in a graded manner from lowest dose to highest dose, and you can see at this particular dose the clearing begins. So this is what describes the MIC, and this test is what is called as the E test or the epsilometer test, which can quantitate the drug sensitivity, right? Now talking about the motility. So just a summary list, most of this we have already done. So tumbling, remember, listeria. Darting motility was Vibrio. Swarming, the typical one is Proteus, and I've just added the others here. So parahemolyticus can show swarming, tetani, Bacillus cereus, and Serratia. So these are the others which can show swarming as well. So this is one more extra point here. Corkscrew motility was Treponema. Lashing is Borrelia. Remember, loose and lashing. Now, two protozoal parasites here. So, falling leaf, I'm sure you remember, is Giardia. Remember, simple bone cyst, where we had seen the falling leaf sign of pathological fracture. This is falling leaf motility seen in Giardia. You also have the string test or the entero test. We saw a string sign in Vibrio. This is the string test, okay? So, this is where this is useful in patients where we are not able to see the eggs. Normally, the eggs of Giardia or the cysts of Giardia can be detected in the stool, as I'll show you. But sometimes if we are not able to detect and we are suspecting this is Giardia, because Giardia is a typical presentation, this is the only organism which can cause malabsorption, right? So, if you're suspecting, what you can do is you can take this tube sort of a thing with a thread and you pass it in the duodenum, and these trophozoites can hang on to the thread, okay? So that's not very important, but that's what a string test useful for Giardia. Whereas quivering and twitching is the other protozoa, which is Trichomonas. So now what you want to remember, what does Giardia look like? So look at this image. Can you see how it is sickle shaped with two nuclei? There are 4 anterior flagella, 4 posterior flagella. So this kind of looks like an angry uncle. So from today, Giardia is our uncle. Giardia uncle with 2 eyes, 8 hair. Does uncle have kids? Yes, uncle has a kid who is the cyst. So this is the trophozoite form. This is the cyst form which is detected in the stool. Doesn't the son look like father? It does. You can see 2 nuclei but 0 flagellae, right? So this is what is the Giardia cyst. Coming to Trichomonas. Trichomonas causes cervicitis, so we have to call it auntie. So auntie has only one eye. Imagine one big auntie wearing this big bindi. Okay, bottu in Telugu is bindi. So when you see one big nucleus here, what you want to remember? Auntie has 4 anterior flagella and 1 posterior flagella, right? So this is our angry auntie. What do you want to remember about auntie? Does auntie have kids? No, auntie doesn't have kids. So auntie only exists as single trophozoite. There are no cyst forms to auntie. First point. Auntie moves with quivering or twitching motility. Okay, fine, good. Auntie loves talking about culture. So auntie talks a lot about our culture. And what does auntie love? Auntie loves diamond. So you can remember that auntie can be cultured on diamond media. And you can also remember auntie likes to eat strawberries. So auntie trichomonas causes strawberry cervix. Okay, so this is all that you need to remember about giardia and trichomonas, which is what we finish here. Just to finish off the culture media, right? So I'm showing you 4 culture media where we need to know little bit more detail. So first of all, identify this one. This is McConkey agar. McConkey agar has lactose. Okay. So this is what I am using to differentiate lactose fermenter versus non-fermenter. So you can see lactose fermenter are pink, non-lactose fermenter are yellow, and the indicator here is neutral red. Second, the culture medium which I have here is the clad medium. Clad medium is the one we were using for E. coli, right? So this is where I also have lactose. So this goes with the flow that this also has lactose, but the indicator here is bromothymol blue. You can see that it's blue here. And the lactose fermenters are now going to be yellow. So what you see here as yellow are the lactose fermenters, which are your E. coli. So this is how E. coli colonies look. Next, what I have is the mannitol salt agar. So what I am doing is now we are taking off from this mannitol salt agar. I am obviously adding mannitol. The mannitol fermenters are gonna look yellow, right? So the fermenters are yellow now, and the indicator is phenol red. And the last one is our Vibrio cholera TCBS agar, where I am now using sucrose, right? Thiosulfate citrate, bile salt, sucrose. Sucrose fermenters are still yellow. Indicator is the same as clad, which is bromothymol blue. So how to remember this? Why I've arranged it this way is lactose fermenter or the fermenters are always yellow except McConkey where they are pink. Yeah. So the sugar may differ, but they are yellow except McConkey where they are pink. Indicator do it in 2 pairs. First and third we have something red, neutral red, phenol red. Second and fourth, we have bromothymol blue. So this is the easiest that this can get. Otherwise, it's very tricky. If you do it in 4 different places, there is no way you can remember. So this is the only way you can remember that fermenters are yellow, except McConkey. First 1 and 3 are red, 2 and 4 are bromothymol blue, right? So this is about the culture media. Next, we talk about rickettsia. So this is a page again which is very volatile but very important, very dense. We will cover rickettsia here. Rickettsia are again organisms just like mycoplasma and chlamydia who do not take up the gram stain. These are obligate intracellular organisms. So rickettsia, we need to know the disease, the rickettsia organism and the vector. 3 things we have to do first. So when we talk about rickettsia prowazaki, you see a P here. This is called as Brill-Zinsser disease. P for epidemic typhus, right? So this causes epidemic typhus, whereas our typhi, the name has typhi and epidemic is taken. So this is endemic typhus. And this is what has this Neal-Moser reaction. You can just read it once. Epidemic. What is epidemic? Love is epidemic. So louse is the vector for this also, and epidemic relapsing fever also, and trench fever also. So that finishes louse for us. But here, endemic is not soft tick like relapsing fever. Here you want to remember Flint. You know Andrew Flintoff was an English player. I mean, he's still alive, but doesn't play. So Flintoff. So you want to remember flea is endemic typhus, right? So Flint will help us remember that this is flea. So 2 things with flea, one is rat flea for bubonic plague and one is flea for endemic typhus. That finishes flea for us. Now the next full category is where the vectors are going to be hard tick. So R. rickettsii, so important that we call it twice. So rickettsii is what is our Rocky Mountain spotted fever. Remember, does the rash involve palms and soles? Yes. So this is where it was involving palms and soles. So can I say now that typhus must not be involving palms and soles. Yes, and that is how we can clinically distinguish typhus from Rocky Mountain spotted fever. Very important. Are Konori causes Indian tick typhus? Sounds like an Indian name, no? Konori. Whereas Afrique causes African tick typhus. So this is probably the best one. African tick typhus. Ehrlichia anaplasma causes Ehrlichiosis anaplasmosis transmitted by heart tick. Here what they ask you is where are these living? So you want to remember game. So game is a very useful mnemonic. Anaplasma is in the granulocyte, whereas Ehrlichia is in the monocyte. So this is what was asked, that which lives in the monocyte. The answer was Ehrlichiosis. So this is all about hard tick. Going on to our Akari, this is what causes rickettsial pox. So this is the one which causes pox-like lesions, whereas our Shushugumashi causes scrub typhus. Okay, both of these are spread by mite. How I remember is it takes a lot of might to say shushu gumashi. Try it, say it 3 times, you'll realize it takes a lot of might. Okay, so rickettsial pox, scrub typhus. Now we know the features of all of these diseases. So this doesn't involve palms and soles. This does. This is pox-like. What about scrub typhus? So scrub typhus is the lesion. This is a repeat question which produces this black discoloration. That is eschar. So eschar is seen in 3 infections in general. One which we are studying is scrub typhus. Second, which I already described in zoonosis, animal workers, was cutaneous anthrax, and spider bite, recluse spider bite can also cause eschar. So this can be asked as an all except question, and in fact has come once in the exams, right? So this is about scrub typhus, and the final one is Coxiella. Coxiella is watching all this, what's going on this page, my god, and it says that Q I should remember so much. So it causes Q fever, and it says that okay, fine kids, I will not have any vector for you. I will spread by inhalational route. But the irony is, before we knew this, everybody thought it was soft tick mediated. So now we have to remember both. Okay, so this is what is about Coxiella Q fever. Now, Coxiella is that one friend, no matter what plan you make, they're always gonna say no. I don't want to come. You say, chal Goa chalte hain. They're like, no. Chal movie dekhne chalte hain. They'll be like, no. So that's what Coxiella is. You tell Coxiella, chal Jeemsa stain karte hain. You'll be like, no, I don't want to go. Let's get killed by pasteurization. It's like, no, I will not be killed. Then, if you tell Coxiella that, come on, let's become positive twice for infective endocarditis. What was the IE criteria? That it should be positive in at least 2 media. Will this friend who goes nowhere come along? No. So we're like, okay, fine, you just come once and we'll accept you as positive. So Coxiella is where only one culture is taken as positive for infective endocarditis, and we remember reading this in the table, right? So this is how we remember Coxiella, and it also produces donut granuloma. Remember, I'd shown that image in PATH, okay? So that's what we need to remember here. The final thing about rickettsia is what is called as Weil-Felix reaction. So this Weil-Felix reaction is a heterophile agglutination test. This is where heterophile agglutination means 2 different species cross react. Okay, so this is where I'm taking Proteus species antigen, and that is what is going to cross react with rickettsia. How to remember this table? So only OX19 is typhus, whereas OX19 and 2 is your Rocky Mountain spotted fever. How I remembered this is palms and soles are 2, right? What involves palms and soles? Scars are for Rocky Mountain spotted fever. So when you have 2 palms and soles, 2, it's RMSF. If not, 19 is common, I remember. So just remember CARS and you're already sorted. OX2 matlab Rocky Mountain spotted fever. Clear? And K matlab K. Scrub typhus is OXK. So this is for scrub typhus. Clear? So this is how we remember Weil-Felix reaction. Now, we have been talking so much about all of these vectors, right? So let's just finish this from PSM point of view, the identification of these vectors here itself. So see this, when you see this flat thing, flat matlab flea. So this is what is your flat flea. Where did we study flea? You remember flint. So flea is endemic typhus. And apart from this, this is what was the rat flea vector for bubonic plague. So again, rats serve as two buzzwords for you. One is bubonic plague rat and one is leptospirosis rat urine. Okay. For rat flea, there was an index called Cheopsis index. Just want to remember Cheopsis index here. Look at this one, so shiny, shiny. When do we wear shiny clothes? When you are in love. So this shiny, shiny thingy here is love. And do we know everything about love? Yes, love is epidemic. So what two epidemic things? Epidemic typhus and epidemic relapsing fever. And it takes you to trenches. So trench fever, Bartonella quintana. Yeah, so this is louse. Then when we look at these eight-legged creatures, these are your ticks. When you don't see a head looking like a tortoise, this is your soft tick. Whereas when you see H for head, H for hard tick. So this is your hard tick. Soft tick, what does it cause? Remember, love makes you soft. So this is your endemic relapsing fever. And you want to remember Q fever, Coxiella, right? So that was soft tick. Hard tick was your big, huge list. So we started off with Lyme's disease. Remember Borrelia burgdorferi? So that's done. Then on the last page, what did we see? Most important, Rocky Mountain spotted fever. I don't need to write tick typhus because that's obvious. Then we studied game. What was game? So Anaplasma ehrlichiosis was hard tick. Very, very important, Crimean Congo hemorrhagic fever and Kyanasur forest disease. Both of these are mediated via heart tick. Both of these are endemic in India. Crimean Congo hemorrhagic fever, we get this in Gujarat, whereas Kyanasur forest disease is in Karnataka. Both of these are hard tick. And one thing which I'll show you an appearance for is babesiosis, which is also spread by heart tick, which goes into RBCs and creates a Maltese cross appearance. In fact, let's just finish this right here, right now. So when you see inside RBC, there is this Maltese cross appearance. This is what is babesiosis spread via hard tick. And you want to remember Maltese cross in urine, we already did in biochemistry, in Fabry's, and it can also be seen in nephrotic syndrome, right? Now going back to hard tick. So this was the list here. What is this red? Imagine somebody wearing complete red shirt, red pants, red shoes. Won't it take a lot of might to be dressed like that? Yes. So this complete red guy here is our might. What does it take a lot of might to say? Scrub typhus, right? Shushugumashi. So scrub typhus and rickettsial pox, and mites also show this trans-ovarian transmission once they showed a life cycle where the buzzword was trans-ovarian transmission. And finally, what you can see here, black thingy here is cyclops. We'll study cyclops with parasito, and it is also the vector for guinea worm, which has now been eradicated. We'll study cyclops with Diphyllobothrium latum as well, right? So these are all of our vectors that we needed to do. So now, while we are talking about the insects, let's just finish everything. So we now move on to mosquitoes. Okay, so this is where we are now venturing into the whole National Vector-Borne Disease Control Program. So first we'll talk about mosquitoes, then we'll talk about mosquito and vector-borne diseases, and then we'll talk about, what is the management in terms of PSM for vector control. So everything we are covering here. So first of all, identifying the mosquitoes. So what is this here? So the feature you have to look out for is it is sitting at an angle. So when the mosquito, an adult mosquito, is sitting at an angle matlab Anopheles, right? So this is what is the feature of Anopheles. Anopheles, remember, is a sophisticated mosquito. So you'll remember that it lives in clean water. That's why we say it's a sophisticated mosquito, even though it's a mosquito. It has 5-kilometer range. It lays eggs singly. That's how you remember sophisticated, single eggs at a time, one at a time. So larva is parallel and adult is at an angle, and you'll see spotted wings. But don't look out for spotted wings because you'll confuse it with Aedes. So the only thing here is that the adult is sitting at an angle, and that's what you will look out for. Only one disease, malaria. Male Anopheles, female Anopheles. So if it's doing work, must be Female. So female Anopheles is what transmits malaria, only one disease. Then look at this one. The characteristic feature is that it has these stripes on its body and legs, and it's parallel. So here the adult is parallel, and that is what we look at. So this is what is the Aedes mosquito, and it's referred to as the tiger mosquito because of these stripes. This, remember, has the shortest flying range, which is 100 meters. This also lays the eggs singly, but we are going to identify it with one, the parallel body and the stripes. Aedes transmits all of the important diseases that we need to remember. So don't remember this box. We'll remember the others so that everything is left gets covered here. So dengue, chikungunya, yellow fever, Zika virus and Rift Valley fever is basically transmitted by Aedes. Broughton's index, remember, we follow for dengue as well as chikungunya, essentially for Aedes. And this is where, you're going to go to different houses and see how many containers come out positive for Aedes, because you can see that Aedes collects in artificial water collections. So if there is a dengue epidemic or, a sporadic rise of dengue cases are going on, the MCD, the municipal commission, will come to different houses in that neighborhood and will check that how many of these houses have artificial collections of water and how many come out to be positive. So Broughton index essentially is number of containers that turn out to be positive upon the number of houses which turn out to be positive upon the ones that they see, right? So this is what is Broughton index. You don't have to know the formula, but just that it's for Aedes, it's for dengue, chikungunya, right? Going on to the third one, which is sitting with this hunchback here. This is Culex. Culex lives in dirty water and it has the longest flying range of 10 kilometers. We identify it with this hunchback, and it has a characteristic siphon tube in the larva, and that is what was tested in the exam. Even Aedes may have this siphon tube, but Anopheles does not have the siphon tube, right? So here you can remember that the larva does not have any siphon tube in Anopheles. Culex, remember, will be very, very important. These three lists we have to remember. So one is filariasis by Wuchereria bancrofti, one is Japanese encephalitis, and one is West Nile. So essentially this list you have to remember. So you know malaria already. Once I know these three, remaining everything is Aedes. So what's the list? Revise in your mind. We have Wuchereria bancrofti, WW, West Nile, and J, right? And then this one mosquito with long legs here is Mansonia, and it lives with this Pistia plant, and it's the other filariasis, which is Brugia malai, right? So these are the mosquitoes. Now when I say National Vector-Borne Disease Control Program, these are 6 letters. It covers 6 diseases. What all 6 diseases? So what 5 can you see here which are highlighted? So we have malaria, dengue, chikungunya, we have JE and filariasis, right? So what's the 6th one? The 6th one is this. What is this vector now? So this is our sand fly. Remember, we already saw Oroya fever, right? So that was one sand fly. Now this is the other sand fly borne disease which is included in our program. And what are we talking about? We are talking about Kala Azar leishmaniasis. So Kala Azar gets you questions in every exam, just like leptospirosis. Very, very important. Focus on the buzzwords. You'll get somebody with fever of unknown origin with hepatosplenomegaly, very common in the Bihar, Jharkhand belt in India. RK39 antigen test is something that is done in practice, and that's why very important. Others you want to remember for theory purpose, we have Napier's aldehyde test and you have Montenegro test. These are mostly theory. Another thing we do here is bone marrow biopsy, where you're going to see these A mastigotes. This is what is called as kinetoplast. So you see the A mastigote and you see the kinetoplast, right? So this is what you need to know. These are what are called as LD bodies. LD meaning Leishmania donovani. So Giemsa stain on bone marrow will detect these A mastigotes. You want to remember there is a culture medium called triple N medium. So these are all the points for Kala Azar you need to know. And drug of choice under our program is liposomal amphotericin B. And if this is resistant or this is not available, the next second line drug is miltefosine, right? So this is what you need to remember for Kala Azar. The next part of discussion is now focused on malaria, right? So for malaria, what is the peripheral smear stain that is recommended under our program? That is called as Jaswant Singh Bhattacharya, JSB. So Indian name, JSB stain. So you don't want to really write this. So Jaswant Singh Bhattacharya is what is the stain that we do in the field settings. We do both thin and thick smear. The thin smear tells us about the species of malaria that we'll discuss in a while, and thick smear tells us whether the malarial parasite is positive or negative. The fluorescent stain that may be used for malaria is what is acridin orange. So you want to remember, acridin orange is done for malaria. One microscope under our program is there in 25,000 population. Believe it or not, this also been asked. Now talking about three indices here that are used for malaria demography. The most important measure for malaria control is API. What is API? API is annual parasite incidence. It's not index, it's annual parasite incidence. API is used to classify the various states into control. So API more than 2 is considered to be a high risk area, whereas API less than 1 is considered to be a low risk area. Best indicator for operational efficiency is ABER. What is ABER? It is annual blood examination rate. So how much blood has been examined, throughout the year will tell us how well the ground staff is working, how much are they doing their job. And what is the best during outbreak? That's SPR, that's slide positivity rate. Suppose I examine 10 slides and 8 come out positive, means we are in the middle of an outbreak. If 1 come out positive, not an outbreak, right? Then Duffy antigen absence, remember, is protective. This is what is protective against malaria if this antigen is absent, because Plasmodium uses this as a receptor to enter the RBC. So when this antigen is not there, no malaria. Then coming on to the treatment. So this is important when we talk about Vivax and Oval. Right, so something important here is that they are going to have schizons. Schizons basically will be the merozoite form of the malarial parasite, right? So these are going to cause relapses. So that's why we have to kill this. So to kill the schizon, the drug of choice is primaquine. So in Vivax and Oval, primaquine is indicated. So what do we have to give them? We have to give them chloroquine plus primaquine for 14 days, right? So chloroquine plus primaquine for 14 days, and you can remember the dose of primaquine, it's 0.25 mg per kg for 14 days. The role of primaquine is to kill the schizont and prevent relapse. Whereas for falciparum and malariae species, chloroquine has developed resistance, so that is of no use to us. And primaquine is of no use to us because these guys don't have schizont, so they don't have relapses. So for falciparum and malaria, what we need to do is we have to give them ACT. What is ACT? That is artesunate combination therapy. So that is where we use artesunate plus SP. What is SP? SP is sulfadoxine pyrimethamine, right? So that is where we have to give them SP. So you just want to remember ACT is given for falciparum and malaria. But in Northeast, even this has acquired resistance. So there we give a combination of artemether with lumefantrine. So as I said, LNM stick together. So artemether and lumefantrine is what is preferred in Northeastern states. Now, this NEET exam, they asked that somebody has a mixed malaria, right? Vivax plus falciparum. So, this was this NEET question. In mixed malaria, that too, it wasn't a straightforward question. They asked, what will you give on day 2? So, let's understand the management of mixed malaria. Here, the principle is that you have to give ACT to target falciparum, and you have to give primaquine to target the relapses in Vivax oil, right? So we have to give them both. So ACT, how do we give ACT? So here you want to remember that artesunate is to be given for 3 days, whereas sulfadoxine pyrimethamine is only given on day 1. And primaquine is to be continued for 14 days, as we discussed, 0.25 mg per kg. So this was asked. So artesunate is 200 mg for 3 days, SP only 1 day, and Primaquine 0.25 mg per kg for 14 days. So this is how the treatment is planned. They asked what will you give on the second day. So what would the patient be taking on the second day? Sulfadoxine pyrimethamine was only first day. So this will not be going on. So on the second day, the answer was 200 mg artesunate plus 0.25 mg per kg. Primaquine is what he should be taking on day 2. So they're asking a very, very detailed question on this, and you would have seen that malaria management actually gets you a lot of questions. So I think this is what will take care of everything now, from dose to regimen to everything. So just to repeat, Vivax Ovel matlab chloroquine plus Primaquine for 14 days. Falciparum malaria matlab ACT, where artesunate is given for 3 days and SP is given for 1 day. In Northeast, we replace it with artemether and lumefantrine. What about pregnancy? Let's just finish this right here, right now. So in pregnancy, the deal is Primaquine is contraindicated. So in the first trimester, the drug of choice is quinine. Whereas in the second and third trimester, the drug of choice here becomes artesunate, right? So that is where you give artesunate, and in the first trimester, you give quinine. In severe malaria, we got to give parenteral treatment. So either we give IV quinine or IV or IM artesunate. So parenteral treatment of quinine and artesunate is given, and this is where they had described a scenario of somebody with cerebral malaria and asked you the management. Okay. There is a new candidate. It's been in trial for a long time. That's Mosquirix for the vaccine against malaria, which is RTS-SAS01. All right. So it's a complicated name for the vaccine candidate for malaria. So when I said about pregnancy, one thing you have to remember is this is where I'm talking about falciparum, right? So first trimester quinine, second and third artesunate. For just Vivax Ovel, you just give chloroquine, right? So it's only Primaquine that you have to withhold. Everything else remains the same. So for Plasmodium Vivax and Ovel, you just give them chloroquine, right? So this is what we need to remember here. Now talking about what route of infection. So mosquito bite is going to transmit the sporozoites. Okay, that's the form that's transmitted. Transfusion, trophozoites are transmitted, and in placental transfer, you remember, mera bacha, my child is getting the infection. So remember, merozoite here. All right, so this is how the infection is transmitted. Going on to this card test, very, very important. First of all, whenever you see such a card test, whether it's UPT, malaria, dengue, whatever, the principle is always immunochromatography. So the principle here is immunochromatography. So you have this control which must always be positive, otherwise your result is invalid. Now you check whether it's Vivax, falciparum or mixed. So Vivax, the antigens that we have here are LDH and aldolase. You basically have an L in the name, whereas Plasmodium falciparum, the antigen is HRP2 antigen, histidine-rich protein 2. So just remember, two L's are together. Going ahead and identifying, now we said thin smear is used for identification. What do we see on the thin smear? So look at this. Here you can see this ring form, which is the trophozoite. And when you see this RBC with many dots, these are your merozoites which form the schizont. Okay, so these merozoites form the schizont, and what you have to remember, both of these indicate your Plasmodium vivax or Plasmodium ovale infection. You can't distinguish them. On the other hand, when you see that there are these ring forms, when you see that there are these ring headphone forms, this is the Acol form, multiple headphones. And when you see this banana here, this is the banana shaped gametocyte. And what does this indicate? This is what indicates Plasmodium falciparum. So this indicates falciparum, and this band form here that you can see is what indicates Plasmodium malariae, right? And we already saw Maltese cross with babesiosis. There are few spots, just like names you want to remember. So for Vivax, there are these Schiff bodies, and for Ovale, there are these James bodies. How I remember this is, imagine you're calling somebody called O. James. Okay, O. James, come here. And you know what he's doing? He's a radio FM jockey. So he's working at an FM firm. All right. So this is what is Morier clefts in falciparum, and mer is Z-man. Who is James? James is a man. Okay. So M&M, FM, O James. Fine. So this is the lamest thing ever, but you can remember it this way. Fine. Going ahead to dengue points now. So we did malaria, we did kala azar. Let's talk about dengue. In the recent times, it's become very, very important. Okay. So first thing about dengue is something very unique, a question that hasn't been asked and can be asked, and I'll take a party if it does, is antibody dependent enhancement. Okay, so dengue shows a phenomenon called antibody dependent enhancement, wherein, let's say I've had dengue once. Okay, I actually have had dengue once. Let's say I was attacked by dengue serovar 2. If dengue serovar 2 comes to me again, I have immunity, I have antibodies, they'll protect me. But if I have dengue serovar 3 which comes to me next time, now I will have an even more severe infection. That principle is antibody dependent enhancement, because look at this phenomenon. So these antibodies against serovar 2 which I have in my circulation are now going to welcome that, oh friend, serovar 3 come. They are going to welcome and they're going to take them to the monocytes, which will further increase the viral load. So actually, instead of attacking them, they're going and taking them and actually increasing the viral load somehow. So that's called antibody dependent enhancement, shown by dengue, where when you have an infection of a different serotype later, that's going to result in an even more severe disease. Diagnosis of dengue has been tested. So if the disease symptoms have been less than 5 days, the investigation of choice is your NS1 antigen ELISA. You can also isolate the virus or do RT-PCR. But if it's been more than 5 days, then we do IgM. So they give you these 4 options, 1, 2, 3, 4. What would be the answer? It can only be 1, which is IgM, right? So that's what they did. We are studying less than 5, more than 5. They asked what about 5th day? So it's very obvious, when all 4 are options, there can only be one answer, and that's IgM, right? So you have to sometimes be very smart. They will trap you where you don't even know that you can be trapped. But you have to be very smart in looking at the options, because end of the day, the answer is going to come from the options and not from your memory. Always remember that. So that's about this. AST upon ALT more than 1000 is a danger sign. It's a direct repeat question. There are many other danger signs, but it's too long a list to remember. So remember the answer. Brotto index, as I said, is the number of containers which are positive upon the number of houses which are positive, that we need to know with respect to ADs. Management of dengue is very simple. All you have to do is IV fluids, IV crystalloids, and platelets are only indicated if they are either below 10,000 or there are clinical features of bleeding. Let's talk about the classification of dengue. So just dengue fever, what will be the symptoms? You'll have fever of 2 to 7 days with 2 or more, headache, retroorbital pain, myalgia, arthralgia. That's what you need to remember. So that's simple, any viral fever, right? So that's not important. What is important is this: dengue hemorrhagic fever. That has 4 grades, 1, 2. 3 and 4 become dengue shock syndrome. So what is 1? 1 is where you have symptoms of viral fever plus a positive tourniquet test and evidence of plasma leakage. A tourniquet test is where you inflate the BP cuff at a midpoint between systolic and diastolic blood pressure, and you keep it there for 5 minutes, and the patient will have more than 10 patike. So either these can be more than 10 or they can be more than 20. More than 20 is definite positive, more than 10 is positive. Yeah. So this is tourniquet test. Evidence of plasma leakage, what you have to remember: platelet count less than 1 lakh or hematocrit more than 20%. So in a dengue patient, if you've had dengue, there are only 2 things that are to be done. Give the patient IV fluids and monitor blood count. In blood count also, one thing you have to remember is you measure the CBC. You send the platelet and you send the hematocrit, right? So that's what you have to measure. Platelet less than 1 lakh, hematocrit more than 20%, right? So that's DHF 1. DHF 2 means the patient is telling that I am having symptoms. in the first class, you elicited everything. You saw blood count, you saw tourniquet. Here, patient comes to the doctor, sir, I am having bleeding, or patient has pain. So this is where patient is having symptoms. 3 and 4, as the name suggests, is shock. So 3 means shock. 4 means profound shock with undetectable pulse. So these are the gradings, easy to remember this way. So this we finish dengue. Talking about integrated vector control now. So this is where you need to remember we can do anti-larval measures, anti-adult measures and personal protection. Anti-larval measures are the target in urban areas. In urban areas, we want to target the larva. This can be done by 3 methods: chemical methods, biological methods or environmental control. Chemical methods, most famous one, even though we don't use it, is Paris green, which is a stomach poison, and Temiphos abeta, contact poison. You need to just remember these words, okay? There's no concept here, just remember. Biological, we have Gambusia fish and guppy fish, and we have this Bacillus thuringiensis, which we used to study in school, right? So these are all anti-larval measures. Anti-adult measures are killing with spray. So you would have seen, like, the municipality government people come and do these sprays. So space sprays are general sprays done in low API areas. These are malathion, cyphenothrin and pyrethrum. Okay, so things which are difficult to pronounce, space sprays. Residual sprays are done in high API areas. So residual sprays will include DDT, malathion and deltamethrin. Okay, so if DDT has resistance, then you go for malathion. If malathion has resistance, go for deltamethrin. Personal protection are going to be in our nets, right? So these are the nets here. So we have insecticide treated bed nets, which are all treated with deltamethrin, or we have long lasting insecticidal nets. So in ITBNs are for 6 months, LLN are for 3 years. Again, these depend on the API and the control you want. The weirdest question ever that I have seen in the history of NEET PG is that these nets, what is the size of one hole of this net? It is 0.0475 inch, okay? And there are more than 150 holes in 1 inch, right? So these are legit questions which I don't know why they have asked, but they have asked. So this is all about integrated vector control. Now, next part is mycology. Mycology is the cutest because it's the smallest part and it's the highest yielding part, okay? So here we first do the morphological classifications. There is a true yeast. The only one true yeast that we have is Cryptococcus, right? So Cryptococcus causes meningitis. Cryptococcal meningitis is usually associated with patients who have history of HIV/AIDS. So that is what they'll give you. Patient has HIV/AIDS, or sometimes, in USMLE, they ask that patient has gone to some sort of bat caves, because this is associated with bat droppings and bird droppings. So either caves or birds, something of that sort, an immunocompetent patient can happen. But in our setting, you want to remember, we don't really have bat caves. Bird droppings also we are used to. So we are usually affected in HIV/AIDS, okay? So this is where they'll give you this India ink staining. This India ink staining is an example of a negative stain. What is the meaning of a negative stain? So have you seen these students, or you might be one of them, who highlight their books completely? A few students had shown me that BTR books, in one of the offline classes. I'd asked them that show me your books. Their books were like completely pink or green or yellow or all of the above. And what was actually standing out was stuff which they had not highlighted. Okay, so they'd read it like so many times with different colors all the time that actually which was not important was standing out, right? So that is what is negative staining. That you stain the background such that the bacteria which you are not trying to stain will stand out. Okay, so that is India ink. So this is where the capsule here, this is the polysaccharide capsule which Cryptococcus does have, stands out. However, the better test is this latex agglutination test. Okay, so this is the latex agglutination card test, which is far more sensitive and specific. Okay, so this is what you need to remember. Mucicarmine is a stain for histopath, so not really useful in practice, but otherwise you can remember it's a specific stain. The agar for culture is bird seed or Niger seed agar. So bird seed, right? Because bird droppings are so specific, you put it in your agar and it will grow. And why do we call it Niger? Niger matlab black. Why black? Because I just feel like this question can come, and if it does come, I'll take party. Okay, so this is where they have this enzyme called phenol oxidase or lactase, which makes this colony black in color, right? So that's important. So this is all about true yeast, which is Cryptococcus. Who is the pseudo yeast or yeast like? This is what is Candida. Now you will remember Candida. Everything comes with here. So this is where you want to remember that they are going to have this curdy slash cottage cheese vaginal discharge that they will describe. Then they might tell you that when we are growing it on cornmeal agar, there is the presence of chlamydiospores. Then what is this phenomenon? So this is what is called as germ tube formation, called as Reynolds broad phenomenon. All of these words which I have just said, germ tube formation, Reynolds broad, cornmeal agar, chlamydiospores, all of these are preferentially seen in which Candida? Candida albicans, right? Which is the most famous one. So Candida albicans, and here on this image you can see how there is pseudo yeast formation, right? So you can see that there is this budding here which results in this looking like a hyphae, but neither is this a hyphae nor is this a yeast. It's in between, right? So this is what is Candida. This agar here is the chrome agar, which can distinguish the different Candida species. You can see this color coding, and do you see this pinky cruzi here? So this Candida cruzi is the one species which is resistant to azoles. Imagine your exam is done now, you are free, you got a seat, and now you go to a cruise to relax. Okay, if your parents now tell you that study, open your book, open your video and watch, will you now watch? No, now you will become resistant that ab main nahi padungi. So now you have become resistant. So on a cruise we are all very resistant to work, right? So that's what cruise is. It's on a cruise, it's resistant to drugs, right? So this is what you want to remember about Candida. Can Candida be wiped off? Yes, Candida is the only thing that can be wiped off. So remember, Candida oral thrush can be wiped off. The only thing that can be wiped off. Talking about mold or hyphae. So this is where we have two hyphae organisms. So the first one, these two images have been asked a lot of times. So look at the first one. This is where you have these septae. And you can see that there is this branching which is acute angled branching. So two features, acute angled branching and septate hyphae. What is this? This is Aspergillus. In fact, the name tells us everything. A for acute, SP for septate, acute angled septate, Aspergillus. On the other hand, what do we see here? You can see that the hyphae are aseptate and broad hyphae, ribbon-like hyphae, branching at obtuse angle. This is what is the feature of mucormycosis, okay? Just don't see the history of diabetes. I've seen people reading diabetes and marking mucor, but no, even Aspergillus will be seen in diabetics, right? So you have to see this image, don't just see the history. So this image, very, very important. Going on to dimorphic fungi. Now, as the name suggests, these can have both the features. They will be in cold temperature, they will be mold. Cold is mold. And where do we have cold temperature? Outside the body, right? When you culture, they will show the mold form. But heat is yeast. When we take histopath, right? So histopath or KOH mount, you are going to see the yeast form. So very easy to remember, cold is mold and K is K. Whereas heat is yeast and H is H, right? So what are the dimorphic fungi? These are all the ones which are your endemic mycosis or systemic mycosis. They cause systemic infection and endemic, not endemic in India. They are endemic to US, different states, and that's how their name has become endemic. You will remember this list as HSBC Bank. You know how there is an HSBC Bank. So H for histoplasma, S for sporotrichosis, B for blastomyces, C for coccidio. Now B here actually is cheating. It is when you see two P's and you push them, it becomes a B. So P for paracoccidio and P for penicillium or Talaromyces marnifi, right? So we are going to see each one of them as a flashcard, in detail. Going about one test here, very important. So these beta glucan and galactomannan assay are both the investigation of choice to pick out invasive aspergillosis. It is invasive aspergillosis which is going to show us a positive test for both of these. What you have to remember is where is it negative. So beta glucan will come out negative in B and C. You can remember Bangalore Medical College. Okay, so B or Baroda Medical College, okay, any college. So B, what you want to remember is blastomyces, M is mucor, C is crypto. So blasto, mucor, crypto are negative and it is the best for invasive aspergillosis, right? Moving on to the endemic or systemic mycosis. So I'm going to show you the buzzwords and you tell me the diagnosis. So the first one is the disease that we say mimics tuberculosis. It mimics TB except for the fact that there is no person-to-person transmission here. What are we talking about? We are talking about histoplasmosis. Again, happens in immunocompromised patients like HIV/AIDS. This is called as Ohio disease or Darling disease or Mississippi disease. This is endemic in Ohio, Mississippi areas of the US, right? We don't care about that. Two forms, these are all dimorphic. So what is this? This is the mold form. So mold, what was mold? In cold. So in culture, we are going to see this tuberculate macroconidia. It's so much like TB, we named it tuberculate macroconidia. And the stain that you see here is the lactophenol cotton blue. This is the stain we do to appreciate the morphology. Remember that? And in yeast, in histopath, in heat, we see the yeast. So this is what shows intracellular yeast, right? So this is histoplasma, right? On the other hand, when they describe broad-based budding, this was asked in this NEET 2024, broad-based, two questions from the same slide, guys. So B for broad-based budding, B for blastomyces. Okay, this is endemic in Chicago, North America and called as Gilchrist disease. How I remember is Gilchrist. Gilchrist was an Australian player. I'm sure you know. So that was South, right? Australia is South, down under, and North America. So that's how South and North go together. Fine. Then you have coccidiomycosis. Coccidiomycosis, this question had been asked that what is desert rheumatism? Directly from here. So desert rheumatism, desert means not ice cream desert, it means camel desert. Okay, so this is seen in desert areas, which is California or valley fever, and rheumatism because it involves the joints, right? So that's why rheumatism. What is the yeast form? This is what is the yeast form, which is sporangium with endospores. And what is the mold form? These are called as barrel-shaped arthrospores. Going on to paracoccidiomycosis. So paracoccidiomycosis is called as South American disease, where you see this captain's wheel or Mickey Mouse appearance. And this is also a repeat question. They had asked this broom brush appearance and bamboo bats as a reservoir. This is Talaromyces marnifi or Penicillium marnifi. Okay, so this is also something that produces a red pigment. Do you remember our red bacteria? That was Serratia. This is our red fungus, which is Talaromyces, and there is one more red fungus, which is nothing but Trichophyton rubrum. Rubrum literally means red, so there is no rocket science in finding this out. So remember three things with red pigment: Serratia, Talaromyces, and T. rubrum, right? Now talking about cutaneous fungal infection. So this is where we are going to be learning a pattern-based approach. So look at the first image. This is probably one of the most cliched images, in the history of NEET PG entrance, that they've just stopped asking this since the last 5 years. So what you are seeing here they'll give you that there is a rose gardener. That is what clinches the diagnosis in the first place. So you have the history of a rose gardener who has these nodulo-ulcerative lesions in a line, right? So these are these linear nodulo-ulcerative lesions. Then you see these from rose itself, you can remember rosette of conidia. So this is rosette of conidia, and these bodies are called as asteroid bodies. Okay, so rose gardener, asteroid bodies, rosette of conidia. What is this? This is porotrichosis, one of our dimorphic fungi, right? So this is what is porotrichosis. Remember, rose gardener. Then when you see this, so this is what they ask, that there is a linear lesion, this patient works as a gardener, had a thorn prick. Everybody marked sporotrichosis, because as soon as we hear rose gardener, our PYQ bias tells us has to be sporotrichosis. But look at the image. Can this be sporotrichosis? No, this is something which is subcutaneous linear erythema. So when you see this, always keep your mind open. Look at this question. Don't be in a mindset that what has been asked. Remember, PYQs are good, but they are good as a checklist, that have I completed those topics? The odds of them coming as it is are very, very minuscule. If you analyze the last few year papers, there have been hardly one or two questions which are directly repeated as it is. So the damage of PYQs is far more than the benefit that is happening currently in this lot of students, who have been told that PYQs are important. Do PYQs, just do PYQs. Don't just do PYQs. That is not going to help. Now the risk is more than the benefit when you keep doing just PYQs, because you get into that bias that ye yoga answer, this is what the answer must be. It's not the case. The examiner is not sitting with the PYQs and setting based on that. That's what your perception is. So clear this perception. Now focus on what has been asked. Whatever is your knowledge, your bias, drop it at the exam hall. Then when you are sitting in front of the exam hall, take it as a fresh exam. Every question is different, whose answer is going to come from the options and not from your mind. That's very, very important. Yeah. So what is this? This is what is actually lymphangitis. It is inflammation of the lymphatics. So you had a thorn prick, right? So thorn prick se kya hua? You had inflammation of a lymphatic, and along the lymphatic, this inflammation is spreading, right? So this is what is very, very important. And they asked you treatment here. So this is where you give amoxiclav, amoxicillin with clavulanic acid, that you know as augmentin, right? So this is because it's most commonly caused by staph aureus. Look at this image. This is a person. They'll give you history of walking barefoot, right? So this person is walking barefoot, and you can see that he has these warty vegetations in the foot, and this is what clinches the answer. You can see these copper penny bodies. These are also described as medlar bodies or sclerotic bodies. And what is the diagnosis? The diagnosis here is chromoblastomycosis, right? So this is also something which is now not asked anymore, but they used to ask this a lot. So this is chromoblastomycosis. And when you see this, chronic discharging sinuses, right? So foot with chronic osteomyelitis, chronic discharging sinuses. What did I tell you? Look at the color. If the color is black or dark granules, this is Madura foot. This is Madura mycosis. But if they give you the color is pale, the color is yellow, actino, remember? So this is what is actinomycetoma. So actinomycetoma versus Madura mycetoma. One more condition you want to remember here is called as botyromycosis. So botyromycosis sounds like it's fungal, but it's a misnomer. It's actually caused by staph aureus. So one more differential of this appearance here is botyromycosis. So Madura foot, actinomycetoma, botyromycetoma caused by staph aureus. So now we talk about parasitology. So here the first thing we want to discuss are cestodes. So we're going to be doing it as cestodes, trematodes and nematodes. Okay, so when we talk about cestodes, remember the definitive host here is man. Okay, so now we look at the individual eggs. You'll get these eggs as identification. So look at the first one. The trick here is you are seeing all of these radial striations. Okay, so what is this? This is tinea. All of these brown colored eggs, matlab this is bile stained, whereas if you see non-brown colored, it is non-bile stained. Okay, so this is tinea. Now tinea can be solium and saginata. So we have tinea solium and you have tinea saginata. What is the intermediate host of tinea solium? It is pig, whereas intermediate host of tinea saginata is cattle. Right, so that's how you remember. Ca is Sa. Okay, so solium and saginata. What you want to remember? What causes neurocysticercosis? So neurocysticercosis is caused by tinea solium. So what did we learn in radiology? Here we had learned that tinea solium is acquired through unhygienic, unwashed vegetables, because the eggs of tinea solium are what are acquired through the vegetables, but the larvae is in the pig. Okay, so can it be acquired from eating pork, that is pig? Yes, but more commonly the eggs are transmitted from the vegetables, right? So remember the veg momo story. So don't eat street side veg momo, it will lead to neurocysticercosis. Okay, so this is about tinea. Now look at this one. What is it? Is it bile stained or non-bile stained? It is non-bile stained. So this is what is H. nana. Nana in Gujarati means small. Okay, so I am a Gujarati and Nana means small in Gujarati. So that's how we remember that this is dwarf tapeworm. Now if there is a small baby, Nana baby, will we allow it to be bile stained? No, we will not allow our baby to be stained by bile. So you want to remember that H. nana is non-bile stained. Second, will we give our baby to any intermediate host? No, so no intermediate host. So that is about dwarf tapeworm. Now look at this one. This one thought that being small gives me a lot of advantage. So let me name myself as diminuta and I'll get benefits. But is this small? No, this is a huge organism. So this is what is H. diminuta. Right, so H. diminuta, you want to remember, just the name is diminuta, not its size. So this is what we said, that you are a liar. You are a rat tapeworm. Okay, so this is rat tapeworm, which tells us that the intermediate host here is rat. Fine. And then the last one, the hallmark here is that there is this operculum. Yeah, so this operculum is going to identify Diphyllobothrium latum, D latum. So D latum, remember, has two intermediate hosts. One intermediate host is Cyclops and another intermediate host is fish, and this is how this is called as a fish tapeworm, because fish is the intermediate host. Alright, so fish and Cyclops are our two intermediate hosts here, and this is called as fish tapeworm. You know something from D latum, what we had learned from hemat. Diphyllobothrium latum, remember, is gonna infect the ileum, and that is where we had learned iron fist bro. Do you remember? Iron from duodenum, folate from jejunum, B12 from ileum. So this is why you are going to have vitamin B12 deficiency here, and D latum will lead to megaloblastic anemia. Now, I said something about this having an operculum. What you want to remember is that operculated eggs are something which are a feature of trematodes. Okay, so you want to remember, we can't even diagnose different trematode eggs because all of them are going to look the same. So trematodes are operculated eggs. The only exception where a cestode has an operculum is Diphyllobothrium latum. So that is what we learned here. And there is one more organism called Spirometra. So Spirometra, D latum, trematode. So you can remember STD are operculated eggs. Now what you see here in the table are the multiple skin tests from all of Parasito which I have compiled here, and this is very important. You have got to match the following kind of questions from this. Okay, so Cassoni and ARC5 electrophoresis are they are for hydatid cyst. Okay, so this is for hydatid cyst. Montenegro, negro matlab kala, we had studied this in Kala Azar. Batchman, remember, is for Trichinella. Okay, so this is for Trichinella, and you want to remember that Trichinella is a viviparous organism. It is something where it's only the larva. We are not going to see the eggs, and this is a larva which becomes encysted in the muscles. Okay, so this Trichinella, you want to remember, affects the muscles. So these larvas are encysted larvas. that you want to remember for Trichinella Batchman test. Fairly, we'll study Mansi, Teddy Mansi in a minute, and you want to remember Mansi may be Teddy, but she is fair. So fairly test is for schistosomiasis. Frankel, remember we said Frankel, we have to be frank to say we are a cat person. So Frankel test was for toxoplasmosis. Mazotti O we will learn with Onchocerca. And full-born, which worm is ovoviviparous? So ovoviviparous, it is born as a larva, full-born. So that is Strongyloides, okay? So this is how we are going to be able to remember all of these skin tests. Moving on now to trematodes. So now remember, all trematodes have rules. Schistosomiasis are the exception. We just said that all trematodes are going to have operculated eggs. Exception are schistosomas which don't have operculum, they have spine. So these are the schistosomas, but first let's establish the rules, okay? So schistosoma rule is it has to start with an S, just like spines start with S, okay? So infective form of every trematode is what? It is metacercaria. But schistosoma, it has to start with a S. So for schistosoma, it is cercaria, right? Transmission of every trematode comes from fecal-oral route, but for schistosoma, it has to be S, so it comes from the skin. Every trematode will have sexes which are present in one. So there are hermaphrodite. Okay, so we have hermaphrodite, whereas schistosoma, the sexes are separate. It has to start with an S. Yes. All of the other trematode eggs are going to be operculated, except schistosoma where you have cerce spine. Getting it? So we have to somehow reach an S for schistosoma and you will remember everything in the process. Definitive host for everybody is always man. Primary intermediate for everybody is snail. Now schistosoma wants an S. So it's like fine, I will stop at S and I will have no other intermediate host. So remember, primary intermediate is snail, whereas schistosoma has no second intermediate host. Second intermediate host for the others. So for Paragonymous, it is crab or crayfish. Okay. For Opisthochus or Clonorchis, it's fish. For Fasciola, it's fresh aquatic vegetation. Okay, so it's fresh aquatic vegetation. So this is how we remember everything about trematodes. Now let's look at the schistosoma species on the basis of the spines. So the first one is where you have a lateral spine. So this is S. mansoni. So here we remember a girl, Mansi, okay? We remember Mansi as Teddy Mansi. Now Mansi is very Teddy girl. She'll go after class and ask teacher, please tell me answer, please tell me question of the test. So this Mansi is very Teddy Mansi. So that's what you remember, that this has a lateral spine. Now this Mansi, because of her cheating, will she do well in exam? Maybe. But will she do well in final exam? No. So this is where Mansi, because of her Teda methods, will be inferior to others. Okay. So these are inferior methods Mansi is using. So inferior mesenteric plexus is where S. mansoni goes and lives. Look at the second egg. Is there any spine here? No spine. So this is where there is no spine. This is S. japonicum. So S. japonicum, Japanese are very, very flexible. Why are they very flexible? Because they have absent spines. They don't have a spine. So that's how we remember. And Japanese, you know, are very superior in terms of their tech. So this is what lives in the superior mesenteric plexus. So S. japonicum, superior mesenteric plexus. Now both of these mesenteric plexus eventually leads to portal hypertension, right? They're going to the portal vein. So these will lead to portal hypertension, and this is what we refer to as Katayama fever, also called as stem fibrosis, right? So there is stem fibrosis in the portal tract. So that's what you want to remember is portal hypertension, Katayama fever. On the other hand, look at this egg now. Here you can see that there is a terminal spine, okay? So terminal spine, you want to remember what are terminal cancers? Hematological cancers are terminal cancers. So terminal spine matlab S. hematobium, and you want to remember this goes to bladder, right? Vesical plexus, and we had studied this in radio. Remember the fetal skull appearance, and S hematobium predisposes to S, squamous cell carcinoma of the UB. So you can remember this as terminal cancers are hematological and bladder cancers. So this is S hematobium. Clear? Now with the same concept that we have done, can we solve all the life cycle questions? Yes, all you have to see are the two intermediate hosts. So we see man, I see a snail, and I see a fish. So now can you tell me what the answer is? Pretty simple. This is Clonorchis or Opisthochus. And what is special about Clonorchis Opisthochus? We have studied both of these predisposed to cholangiocarcinoma, right? So they are pre-malignant cholangiocarcinoma. So this is how we can solve life cycle based questions. This is all the concept that you need here. Now talking about nematodes, okay, so this is where the eggs are most commonly asked, and these images are the most important. So look at the first one. This is where this is non-bile stained egg. So non-bile stained, this is Enterobius vermicularis. Enterobius vermicularis, the worm is what is called as a pinworm. Okay, this is what is going to cause, particularly in children, these worms are going to cause perianal pruritus. So these cause perianal pruritus. And you want to remember two tests with pinworm. There is one test which is NIH swab test, and there is a scotch tape test. So you put a scotch tape around the anal canal and we can catch these eggs. Okay, so this is what you want to remember: E. vermicularis, pinworm, pruritus. Next, you see two mucus plugs on the two sides. So what are these? These are the mucus plugs signifying trichuris, trichura. Two plugs, two words, same name. Alright. So trichuris, trichura is what we refer to as whipworm. This is what can lead to, one of the risk factors here is rectal prolapse. So you want to remember that this can lead to rectal prolapse in children. And second, there is something about the appearance of the rectum, whitish plaques are there, and somebody, I don't know who, referred to it as coconut cake, ruined coconut cake forever. So this is coconut cake rectum, which is seen in trichuris, trichura, right? Then the two eggs which we have here are Ascaris eggs. So the one which is rounder, think of it as a pregnant egg because it's rounder, whereas non-pregnant is thinner. So this is what is the fertilized egg of Ascaris. This thinner one is unfertilized egg of Ascaris. So these are both eggs of Ascaris, and Ascaris is the longest nematode that we have. So they keep, I don't know why they still ask this question to us since biology. Till this day, this question has not gone away. So this is Ascaris, which is the longest worm that we have. Out of female and male, who is longer? Female. So female is taller, longer than males. All right. So this is about Ascaris. Then you look at this one. Is this bile stained? Non-bile stained. So this is hookworm. Hookworm has O's. So we can see the O's here in the egg. So this is how we recognize hookworm, and for hookworm we have this Chandler's index. Hookworm frequently leads to bleeding, and that's why this leads to anemia, which is iron deficiency anemia. Okay. What is this now? So this is a larva that I am seeing in the stool. Means this is our ovoviviparous organism, and who are we talking about? We are talking about Strongyloides. So Strongyloides is ovoviviparous, meaning immediately the egg converts into the larva in the intestinal tract, and that's why we see the larva in the stool, and this is the rhabditiform larva. Okay, so this is the rhabditiform larva, and this is the diagnostic form, whereas the infective form, remember, fur, is the filariform larva. Okay, so don't mix the two. What we see here is the rhabditiform larva, and from that only you can remember the full worm is born in the intestine. So full born skin test is for this. Last time NICT, they asked you parthenogenesis. Parthenogenesis means that just one sex is enough, right? You don't have to have male and female here. Only one female or whatever can give rise to Strongyloides. And Circe Strongyloides, Circe, Small. This is the smallest nematode, smallest worm, okay. So longest is Ascaris, Circe small, Circe strongyloides. Then what do you see here? We see cilia. So which is the only ciliated organism? So this is Ballentidium coli. I remember it as Ballentidium cilii. Alright, so you remember ciliated organism, B. coli. So this is all we need to know about nematodes. So now let's compile all of these eggs, okay. So which are the ones which are non-bile stained? So for this you want to remember Neha, okay. So Neha, non-bile stained. Out of this we already actually know. Do you remember hookworm was not bile stained? So here you want to remember that hookworm has two species. The new world is called as Nicator americanus. Yes, you know America, new world. So Nicator americanus is what is referred to as new world. Apart from that, any is any. Yeah. And Ankylostoma duodenale, and again that also tells you that this is living in the duodenum, and we said that hookworm causes iron deficiency anemia. So can you link the two? Duodenum, iron fist, bro. Yeah. So Ankylostoma duodenale is our old world hookworm, okay. Chandler's index. Which was E? E was Enterobius vermicularis, our pinworm, which was non-bile stained. And what was H? Chota baby, remember H Nana, non-bile stained. So this is essentially something you already know. Then the eggs which don't float. So now you want to remember that Neha is wearing a suit. If you drop a suit in water, will it float? No, it will sink. So suit doesn't float. So S matlab strongyloides. U matlab unfertilized egg of Ascaris. This is where they'll trap you. They'll give you fertilized and unfertilized, okay. I is intestinal tapeworm and T is tinea, okay. So don't float, suit. Fine. So this is what we need to remember. Then we go to the ones which undergo auto-infection, means they can self-infect the person again. Auto-infection, remember chest. Actually, don't have to remember chest. Everything is what we have learnt on the two lists above, Neha and suit. C is the only thing which is new, which is Cryptosporidium. So just remember Cryptosporidium, everything else is repeat. H must be what? H Nana. E must be what? E vermicularis. S must be what? Strongyloides from suit. And what must be T from suit? It must be tinea. Right? So this is how we can solve this. So Neha, suit, chest. Now they gave this question in INICT. This is the formalin sedimentation test, and they asked, this question has come twice now surprisingly, in which part out of ABCD is the egg, are the eggs and the ova acquired from the fecal matter. So even if you don't know this question, you can still rule out 50%. It has to be either B or D, because that's where you have the solid part, isn't it? So that's how you have to approach this question. And if I have to take a guess, sedimentation, now must be sedimenting. So that's how you can take an intelligent guess. You will not know everything about everything. But if you can rule out 50% that this is clear, how can it have the ova? This is what you have to do. Fine. So D, what you can see here are the ova or the eggs from the sediment. So B must be what? B must be the debris we are clearing out. What is A? A is ether. We know vowels stick together. And C is formalin. Okay, so you don't have to remember everything. You just need to remember D is where we will get the eggs. Now let's talk about our acid fast. Remember Kinyun's modification, coccidian parasites, and the history you will get for all of them are HIV/AIDS patients with diarrhea, right? So immunocompromised patients with diarrhea. You have 3: Cryptosporidium, Cyclospora, Isospora. So crypto matlab sabse chota. So these are round organisms, 4 to 8 microns, acid fast. You can also be given this image where you will find that these organisms stick to the brush border. Okay, that's important. So they belong to the brush border of the intestinal epithelial cells. Cyclospora is also round but bigger, 8 to 10, and Isospora is oval, largest, 20 to 30 micron, right? So this is very important. The last two, show autofluorescence. Remember this in G6PD, I had shown you autofluorescence. This is one more, alright. Both of them have the same drug of choice, cotrimoxazole. And for crypto, you can remember Nita Ambani has a lot of crypto. So, nitazoxanide, cryptosporidium. Fine. So, now let's finish the pharma of other eggs also right here, right now. Cestodes and trematodes. The drug of choice for this is praziquantel. For liver fluke, it is triclabendazole. For hydatid and nematode, it is albendazole. Filariasis, DEC. And Onchocerca strongyloides is ivermectin, right? So this is this whole big table simplified into this much, right? So 5 drugs, antiparasitic drugs, remember them. Going forward into filaria now. So these are viviparous organisms, right? So just as we saw trichinella, this is also microfilaria, which are just worms. We don't have the eggs for them. So microfilariasis, they ask us to identify. So here what do you have to see? The first step is to see, is there a sheath around it? So here there is a sheath. So remember, anything with a sheath means LBW. You know how in cricket, if the ball touches the pad, it's LBW. So that's how we remember pad matlab sheath. Okay. So that must be there. Now, once you have narrowed down 3 options, now we have to look at the terminal end. So look at the terminal end. If there are no nuclei, 0 nuclei, or nuclei have vanished. So you want to remember vanish matlab Wuchereria bancrofti. Look at second. You can see 2 nuclei. 2 matlab bi matlab Brugia. Look at third. You can see them traveling in a line. Line matlab loa. Look at unsheathed now. So here you can see again there are 0 nuclei. 0 matlab Onchocerca. And whatever is left is Mansonella, right? So stepwise, first do LBW, then look at tail end. Unsheath, agar 0 nuclei, 0 Onchocerca, right? Few questions about filariasis from PSM point of view now. So filariasis, as you know, is also included under our NVB-DCP, right? Remember, Culex was transmitting Wuchereria bancrofti, Mansonia, Brugia malai, right? So we have something called as transmission assessment survey. So that's the first question. Second, investigation of choice is again a blood test, right? So you are going to do a blood test, but what is very important is when are you going to do it? So these microfilaria live in the lymphatics. They come out into the circulation at night. So either you can do a test which is nocturnal blood test from 10 p.m. to 2 a.m. or we can do a DC provocation test, right? So you can give DC that makes the worms come out. So remember the blood test with 2 things. This little extra concentration can be done with membrane filtration, and there's something called as NOT method where you use 2% formalin. And what is the drug of choice? So the drug of choice is DC plus albendazole, and if needed we can also give ivermectin. So essentially we are using all 3 of them, and you can also remember that these 2, DC and albendazole, we use it for mass drug administration, and as we have remembered 2 drugs, this is given by annually. Okay, so this is what is mass drug administration for high risk areas. Alright, so this is all about filariasis. Now let's talk about trypanosomiasis. It's something which is not relevant to us, but just for completion's sake. So Trypanosoma cruzi is American trypanosomiasis. Remember, we were on a cruise, American cruise, and we became resistant. So cruzi, Candida cruzi, resistant to azoles. Add one more part to the story. Where did you go for a cruise? We went to America. So American cruise, here you want to remember CR and everything will be answered. So C is Chagas disease. Chagas disease is what affects the neurons, right? So this can lead to achalasia like megaesophagus. It can lead to megacolon, right? So it can mimic Hirschsprung, achalasia. R for redovid bug. So the vector here is redovid bug. And you can see how the eyes are swollen. So this is called as Romana sign. Okay, so this is cruzi. Brucey is African trypanosomiasis, which is sleeping sickness. So this is what is sleeping sickness. Circe sleeping, Circe sesse fly. Okay, so this is what is CC fly. African trypanosomiasis, you want to remember that this NNN medium, we use it for Kala Azar and we use it for trypanosomiasis, 2 places, right? Going on to this image now. So, anytime you hear HIV AIDS positive having an intracranial infection, the most common intracranial infection is what? It is toxoplasma. So, you want to remember most common cause of infection is toxoplasma. So, on the MRI, you can see these multiple lesions here, multiple ring enhancing lesions. Think of toxoplasmosis. Here, toxoplasma, you want to remember, happens because of cat. They'll mention something about the cat being a pet, okay? So, transmission by cat feces. So, let me say in a class, I asked you, how many of you are cat people, okay? So, many of you will say that, yes, ma'am, I'm cat people. And you know what others do? All of them hoot and they say, ooh, you are a cat person. So, this is what you want to remember, ooh, cat person. Now, imagine somebody eating a cat. Cat meat say transmission. You'll feel very bad, right? You'll have bradycardia, your heart will slow down for that cat. So when you remember somebody eating cat meat, matlab bradycardia, bradyzoid. Vertical, mother to child, whatever is left is tachyzoid. Okay. Now, to say that, ma'am, I'm a cat person will take a lot of frankness. Okay, so you have to be very frank to say that you are a cat person. So you remember Frankel test, and then who was doing? Ooh, sub. Everybody was doing. Okay, so you remember Sabin-Feldman test. What is that? That is a complement fixation test, right? So this is what is a complement fixation test. So this is what we need to remember about toxoplasmosis. Next, we talk about virology. So in virology, you have DNA, RNA virus. Within DNA virus, all DNA viruses are double-stranded except parvo. So we will remember parvovirus matlab pariah virus. Will anybody give their envelope to pariah virus? No, they won't. So pariah virus is non-enveloped. It's the smallest virus. On the other hand, double-stranded DNA could be non-enveloped or enveloped. So enveloped, you want to remember, imagine you bought an HP laptop. Will it come in a box? Yes. So HP will be enveloped. So you want to remember herpes and pox virus. Let's go to pox for a bit. Now pox virus is the largest virus. Every other virus, every other DNA virus has an icosahedral symmetry. But will the largest virus follow it? No. Large people like to be different. So pox virus is different. It has a complex symmetry. All DNA viruses will replicate where? Nucleus. But do large people like to be different? Yes. So this decides to now replicate in cytoplasm. So here we can see all DNA viruses will replicate in nucleus except largest, which is pox virus. And these are brick shaped viruses. So large bricks is what we can remember. Now, what are pox viruses? So pox viruses are very easy to identify. Anything whose name has pox is a pox virus except chickenpox, right? So chickenpox is what? Chickenpox is our varicella zoster. So now remember that chickenpox is not a pox virus. Whereas which pox virus does not have pox in its name? That's molluscum contagiosum. So molluscum contagiosum is a pox virus but doesn't have pox in its name. Everything else, monkeypox, foulpox, smallpox, not chickenpox. Others are all pox viruses, right? What are herpes viruses? So obviously HSV1 and 2, varicella zoster, CMV and EBV, and then you have HHV6 and 7, right? So all of these are herpes viruses. So you want to remember varicella, CMV, EBV all come under herpes virus, which are all enveloped viruses. So HP laptop comes in an envelope. Who is this enveloped virus that is becoming RNA? God made it a DNA virus and now this is becoming a smaller creature. RNA virus. Who is this guy? This is hepatitis B. Clear? Then we go to non-enveloped. So in non-enveloped virus, now you want to remember first, we have adenovirus. Adenovirus is shaped like a spaceship. Okay, so the shape is like a spaceship. What do we do with spaceship? We use it to transfer stuff. So that's a vector. So you want to remember that adenovirus is used as a vaccine vector. Okay, so you must have heard of Covishield. So in Covishield in PSM we will learn chimpanzee adenovirus. So that is called as ChAdOx. So chimpanzee adenovirus, and the ox was because of the Oxford trial. Okay, so that's what you want to remember. Adeno is most commonly used as viral vector. Then you want to remember we have papilloma virus and we have polyoma virus. So this together, this family is Papova, which makes up for papilloma and polyoma. Papilloma is simple, it's our HPV virus, Condyloma acuminata. Polyoma has multiple small names. One is BK virus, one is JC, and one is SV40. Okay, so BK, JC, and SV40. BK virus you want to remember as bad kidney. That's a mnemonic there, bad kidney. Why bad kidney? Because it affects the grafts, right? So it affects the renal graft. That's how we remember bad kidney. And what we have here are decoy cells. So this can be a potential question, decoy cells. JC, remember this as junky cerebrum, matlab affects the brains. So this is what leads to PML. What is PML? Progressive multifocal leukoencephalopathy. So this attacks the brain, progressive multifocal leukoencephalopathy, junky cerebrum, and this is what happens in HIV AIDS patients. And we have SV40. So this is what we need to remember here. Now talking about RNA viruses. So RNA viruses, all RNA viruses are single-stranded RNA except rota. So rotavirus. Now RNA virus classification is huge. You can't possibly remember it. So if you remember everything from this box very well, I can assure you, you will answer every single question. Okay, so single-stranded RNA except rotavirus, which is double-stranded RNA. That's the first thing. Rota is always the exception. Rota matlab wheel rotates. Last to last NEET, you had a question on what is the investigation of choice. You want to remember it is antigen detection in stool. Now, which are the viruses which are non-enveloped? So, not except here. Which are the viruses which are non-enveloped? You want to remember PERK. Okay. So, P for Picorna viridae, Picorna viruses. E for hepatitis E. R for Rota. And C for Calliciviridae. Okay. Now, the thing is, Picorna is a huge group. So, here further we have 5. So, you remember PERK and PERCH. Yes, PERK and further PERCH. What comes here? P for polio. E for echovirus, which can cause meningitis. R for rhino, your common cold virus. C for Coxsackie virus. And H for hepatitis A. Okay, so hepatitis A and E are both non-enveloped. Now, this was asked as a question that, we have a compound which can destroy the envelope. So, out of the following viruses, which one will not be affected? And they gave Hep A, B, C and D. So, what would be the answer? Answer would be Hep A, because A doesn't have a non-envelope, right? So, nobody can destroy it. So, that's how this question will come. Apart from this, once they add what is measles? Does it have an envelope? Is it there in the non-enveloped list? It is not. So, all of the others are enveloped, right? So, that's how you remember this. So, you remember what are the enveloped ones as well. Everything else is enveloped. Then we come to copies. So, every virus has a single copy of the genome except the retroviruses. So, retroviruses have 2 copies. So, retrovirus means HIV, and don't forget, most people forget HTLV. HTLV matlab human T cell leukemia virus. Okay. Unsegmented. So, everybody has unsegmented genome except Bira. So, now you want to remember that Bira, if I drink too much Bira, multiple segments of my personality will come out. So, B matlab Bunya viridae. I matlab influenza viridae. R matlab always the exception, Rota, and A matlab arena. Now, if you want to know how many segments, Bunya is 3, influenza is 8, Rota is 8 plus 3, 11, and in any battlefield arena, 2 people will fight, right? So, that's how we know arena. Now you would be wondering, why should I remember all this, ma'am? So imagine I show you this image, okay, and I tell you what is this virus. So now you can just see, okay, 8 segments, matlab influenza, right? So this is how these segments will help us. Going ahead with the last exception here, so nucleic acid replication. Now for RNA viruses will happen in the cytoplasm. What is the exception? Here the exceptions are RIM. You want to remember RIM. R for retroviruses, obviously, because they become DNA, and two main exceptions you want to remember, I for influenza and measles, both of which replicate in the nucleus, right? So this is about nucleic acid replication. Now let's talk about the cytopathic effects here, okay? So these are very, very important image-based questions. So look at this one. Here, first of all, what's the diagnosis? So this can be asked as a derma question. So this is described as these lesions with a dome-shaped central umbilication, right? So the central umbilication is what we are seeing here. So dome-shaped central umbilication. And when you look at the bodies here, you can see these big bodies. These are HP bodies. What are HP bodies? These are Henderson-Patterson bodies. Don't remember full form. They will remember. Okay. They will remember and give in the options. We just have to mark it. So these are HP bodies. Where do we see this? This is molluscum contagiosum. So you want to remember, molluscum contagiosum is a pox virus, largest virus, and that's why you are going to have these big names. Henderson, Patterson. Look at the stain of molluscum contagiosum. Lendrums, floxine, tentrazine. Not going to remember. Just remember big name matlab molluscum contagiosum. Now, while we are talking about pox virus, let's finish the bodies. So, these guarnieri bodies, G, C and G go together. So, this is vaccinia. Okay, so C and G. Paschin bodies are variola, which are smallpox. Foul ball. Remember ball. Ball can be foul. So, this is foul pox. Okay, so these are the other pox virus and their bodies. Look at the next image. You can see here, these are negri bodies. Where do we find them? We find them in rabies. What is the shape of rabies? It's a rhabdovirus. Remember, it is shaped like a bullet, right? So, bullet-shaped negri bodies, very high mortality. You'll have hydrophobia. And remember, we use a stain called Seller's stain. And you want to remember about rabies, that rabies affects the large neurons. So, it affects the Purkinje cells in the cerebellum, and it can also attack the hippocampus. Alright. So, these are the points about rabies. Look at the next image. This is where we see our 3 M's. What 3 M's? So, you're going to see multi-nucleate giant cells, right? So, they're going to write multiple nuclei. You will see molding and you will see margination. So, molding multinucleated giant cells usually does the trick. You don't need to know the other 2 M's. So, what are we talking about? We are talking about herpes simplex, and they'll mention that we are doing a zinc smear. So, herpes now. So, herpes you also want to remember with respect to Cowdrey body. So, these Cowdrey inclusions are all intranuclear inclusions. Okay. So, we have Cowdrey A and we have Cowdrey B. Cowdrey A is seen in hay. So, remember hay. A for Cowdrey A, it's seen in herpes and yellow fever. Both of these also have individual names now, okay. So, Lipschel bodies are referred to as herpes simplex bodies and Taurus bodies are yellow fever bodies. Very, very important. Yellow fever was ADs. Taurus bodies affects the liver, okay. And Cowdrey B bodies, remember hay, BAP. Hey, BAP. So, Cowdrey B is seen in adenovirus and poliovirus. Okay. So, BAP is adeno and polio. Clear? Now, going on to the next one. So, if I say this is a pap smear, I think you will probably guess it. This must be HPV. So, that's fine. But what do we call these cells? So, this perinuclear clearing that you are seeing, this is what is referred to as koilocytes. So, remember, koilocytes doesn't indicate CA cervix. It just indicates that we have been infected by human papilloma virus. Okay, so this is about HPV. Now we have two infections which have intranuclear plus intracytoplasmic inclusions. Okay, so intranuclear plus intracytoplasmic. So look at the first one. This is where you have multiple cells. So this is what we refer to as Warthin-Finkeldy giant cells. So these are Warthin-Finkeldy giant cells. Where do we find these? We find them in measles. Very, very important. Second image, very commonly asked, this NEET also this came. You are seeing this owl eye appearance. But what kind of owl eye? Blue owl eye, right? So this is basophilic owl eye and this is CMV. Do you remember the eosinophilic owl eye? Where did we study this? We studied it in hemat. So, eosinophilic owl eye we had studied in Hodgkin's lymphoma, which is the Reed-Sternberg cell. So, owl eye appearance, two places, CMV and Reed-Sternberg cell. And while we are talking about CMV, CMV comes under herpes virus family. And you want to remember one more thing specific about CMV is it can be cultured on human fibroblast cell line. Okay, so that's important. Human fibroblast cell line for CMV. Right, so these are all the images. This page is very, very important. Now going on to viral exanthems. Now technically this is a pediatrics topic, but while we're talking so much about viruses, it's best to finish it right here, right now. Okay, so viral exanthems. Exanthem matlab rash. So these are the viruses which cause rash and fever. But slight misnomer, scarlet fever is not caused by virus. It's caused by group A strep, right? So this is something which is also included because of its fever and rash, but caused by bacteria. So let's look at this. First disease matlab measles, paramyxovirus. Okay, so this is measles, also called as rubeola. The most common cause of death in measles is it's actually because of pneumonia. Now, measles, you will have fever, you will have rash. Okay, so the rash starts from behind the ears and then it will spread in the rest of the body. You want to remember the hallmark spots. The same image comes so many times against the molars. These are Koplik spots. Okay, so measles, Koplik spots you want to remember. Delayed complication of measles. They'll give you that there is a child, unvaccinated child, had a viral exanthem and he recovered, years passed by and now he has a deteriorating school performance. So this is how it's given and the IQ is decreased. So what is this? This is SSPE. SSPE is subacute sclerosing panencephalitis. So I think the name tells you subacute sclerosing panencephalitis. Alright. So this is SSP. Another thing about measles, you can give this vaccine in disaster. What does this mean? That for example, there is a measles outbreak. Normally any disease outbreak, there is no point of giving that vaccine to the population because the incubation period of the disease is always shorter than that of the vaccine. So the disease will actually spread before you give the vaccination, right? This is the only vaccine where the incubation period of the vaccine is shorter. So if I give this in a measles outbreak to the patients, susceptible patients, this will help, right? So that's the meaning. This is about measles. Second disease, sir, is scarlet fever, asparaginase. Again, fever with rash. Hallmark of rash, you are going to hear two words. There is a desquamative rash and this desquamative rash is described as a sandpaper rash. So this is described as a sandpaper rash and these lines are called as pastia lines. Okay. Now you want to eat pasta but you also want some fruit. Which fruit do you choose? You choose strawberry. Why? Because strawberry tongue. Alright, so scarlet fever will have fever, rash, strawberry tongue, can have red eyes, desquamative rash. Now, whenever I say strawberry tongue, what comes to mind? What is the mimic of scarlet fever? Is Kawasaki disease. So now how do we distinguish Kawasaki from scarlet fever? Let's finish it right here, right now. Very, very important PEDS topic. So Kawasaki disease, you want to remember the criteria is crash and burn. What is crash and burn? I need burn meaning fever for more than 5 days and crash. Crash is conjunctivitis. Very, very important, bilateral non-exudative conjunctivitis. So this word non-exudative, it's not purulent, it's redness. Second is rash. This rash will spread throughout the body, will also involve palms and soles, and there's also going to be swelling. Okay. Adenopathy is what will really help you distinguish it from scarlet fever. Adenopathy is a hallmark, particularly an enlarged lymph node. So, enlarged lymph node, think Kawasaki. Pastilla-line, sandpaper words, if you hear, think scarlet fever, right? Strawberry tongue, seen in both. Hand swelling, more in Kawasaki, but not very, very specific, right? So, this is how you have to remember. So, this is what is our strawberry tongue, okay? Does look like a strawberry. Right. So, this is the criteria. What is the most threatened complication of Kawasaki? So, the most threatened complication is coronary artery aneurysm. So, the coronary artery can form aneurysms, right? So, that is something which is very, very important and very life threatening, because this can lead to pediatric MI, and that's why we have to treat every case of Kawasaki. And just for the sake of it, if they ask you most common complication is myocarditis. So, you want to remember MC. Myocarditis most common, but most threatened is our MI, alright, coronary artery aneurysm. How to treat this? So, you want to remember IVIG plus aspirin is used for the treatment. Aspirin. We never give aspirin in children except this indication. Why not? Because aspirin can lead to Reye syndrome. What is Reye syndrome? This is basically acute liver failure that can happen because of aspirin use in children in viral illnesses. That's why we never give aspirin in children, because if the child has other viral illnesses and you give it, this will cause acute liver failure, and if you do a biopsy, you may get microvesicular steatosis. Yeah, so steatosis, Reye syndrome, acute liver failure in children because of aspirin. So, this is about Kawasaki's. Going back now to third disease, that is rubella. Okay, so in rubella, the specific spots that you see here at the palate, what are they called? Are in rubella, are in Forsheimer spots. So, these are Forsheimer spots in rubella. Very similar spots we may also see in the sixth disease, and those are called Nagayama spots. So, you want to remember, no R here. So, Nagayama spots are HHV6. Okay, both are very similar looking on the palate. So, other symptoms will help us distinguish. Fourth disease doesn't exist. Dukes don't exist. Dukes disease doesn't exist. Fifth disease, very, very important, is erythema infectiosum. So, this is what is caused by parvovirus B19. So, you want to remember parvovirus B19, erythema infectiosum. Now, this is what binds to the P antigen and enters the RBCs. So, it enters RBCs, or better still, enters RBC precursors. So, this is where the RBC precursors, you can see these are called as dog ear inclusions, and this is why they cause pure red cell aplasia. Very, very important. RBCs affected, pure red cell aplasia, and you can see this baby here. Look at the appearance. This is called as slabbed cheek appearance. So, erythema infectiosum leads to this classic slabbed cheek, very, very famous question, erythema infectiosum. This is not it. Because of pure red cell aplasia, and parvovirus can undergo transplacental transmission. So, if there is a baby who has this, right? So, the baby having aplastic crisis in utero, and the baby will undergo anemia leading to hydrops. So, this is the infectious cause of non-immune hydrops. So, if they ask you who is or what is the most common cause of infectious non-immune hydrops, our answer becomes parvovirus, because it affects the RBCs, causes aplastic anemia. And while we are talking about this, the last thing which is pretty rare, parvovirus can actually cause something called as PPGS. PPGS is papular pruritic glove and stocking syndrome. Okay, don't be scared, just for an extra edge. Okay, so you can have this periphery of the digits, periphery of your limbs getting affected, papular pruritic glove and stocking syndrome. So, these are all the points about parvovirus. Finally, sixth disease, because this is caused by HHV6. This is called as roseola infantum or exanthem subitum, and we remembered Nagayama spots happen because of this. So these are all of our viral exanthems. Now talking about few specific points from virology. So when we talk about Epstein-Barr virus, now very important, this is what is going to lead to fever, cervical lymph node enlargement and hepatosplenomegaly. So from the first two words, it will be like any other URTI until you see hepatosplenomegaly. So this is what is your classic infectious mononucleosis. So infectious mononucleosis caused by Epstein-Barr, very important. This happens in adolescence, right? So this is what is referred to as the kissing disease because this spreads via saliva, so seen in adolescence. Extremely important, this hepatosplenomegaly can lead to splenic rupture. So that is why, because it's a viral illness, you don't need specific treatment, but you have to advise them to avoid contact sports here, right? So contact sports avoid karna hota hai because they can have splenic rupture. How to diagnose it? How to diagnose infectious mononucleosis? So various things. First of all, look at the blood smear. Look at these lymphocytes. These lymphocytes have these folds which is looking like ballerina skirt appearance. So this is called as ballerina skirt appearance, and these are CD8 T cells. Okay, so ballerina skirt, you might wonder that this must be B lymphocytes. Why would you wonder these are B lymphocytes? Because Epstein-Barr virus, remember, enters via CD21, which is the hallmark of a B cell, right? But the thing is, when we look at it on the blood cell, these are cytotoxic T lymphocytes. So remember that, and these cells are called as Downey cells. Okay, so these are Downey cells, cytotoxic T cells. Coming back, apart from this, when you mix the patient's blood with other species, sheep or horse RBCs, there will be agglutination. And what have we studied? This is what is called as an heterophile agglutination test. And the name of this test is Paul Bunnell test or monospot test. So we have Paul Bunnell or monospot test where you are going to see this heterophile agglutination happening. Okay, so this is what is Epstein-Barr virus. CD21 B cell is how it enters. Because it enters into B cell, remember, it is immortalized, and that's why it leads to so many cancers. Very important. EBV we studied with Burkitt, diffuse large B cell. In ENT we'll study with nasopharyngeal, Hodgkin's lymphoma, CA stomach, and very important, last to last neat question, oral hairy leukoplakia, where they'll show you this white plaque frequently on the lateral surface of the tongue, right? So they asked what is the cause. Can it be rubbed off? No, nothing can be rubbed off except candida, right? So this is very important. Talking about next image. So this is pretty simple spotter. When you see these vesicles along a dermatome. So dermatomal distribution, elderly person, what is it? This is shingles, right? So this is shingles or herpes zoster reactivation. So this happens because varicella zoster remains dormant. Let's say you had chickenpox and now it lay dormant. As you grow older or you have some sort of immunity deficit, this will reactivate along the dermatome where it was dormant. So this is varicella zoster reactivation. Shingles. Shingles will heal, but the problem is that neuropathy will remain. So here the biggest complication is post-herpetic neuralgia. So this post-herpetic neuralgia we can treat using any of those drugs which help with neuropathy, like we have studied pregabalin, gabapentin, right? So those are the drugs which will help just as any other neuropathy like diabetic neuropathy. Okay, what about this now? So what is this syndrome? So what did Justin Bieber develop? He had Ramsay-Hunt syndrome. What is Ramsay-Hunt syndrome? Herpes zoster oticus. Okay, so this is where you have vesicles. Okay, so you have vesicles in the ear, plus what did he have? He had Bell's palsy. So this is where the 7th cranial nerve gets affected. This is called as Ramsay-Hunt, and again this is caused by varicella zoster virus reactivation. Okay, so this is Ramsay-Hunt syndrome. Now let's look at two phenomenon which happen in influenza. Okay, so influenza we know have these H and N, right? So we have HN. Suppose let's say there is H1N3 and we have H2N2. Together they make H1N2, a new virus altogether. This is what is called as assortment. We have a new virus altogether. This is called antigenic shift or drift. This is antigenic shift. Okay, so this is bringing a new baby virus into the world altogether. So this is what is going to lead to sudden large level pandemics. So sudden pandemics, antigenic shift. On the other hand, if you have small mutations which are gradually accumulating, this is what is going to cause antigenic drift. So point mutations, antigenic drift. These will cause gradual low level epidemics. Fine. So quick way to remember this, senior DP. Yeah, Deepika Padukone has now become senior. She is a baby. So she has a baby. So senior DP. Shift, reassortment, drift, point mutation, right? So these are the changes that happen with influenza. Next, we go on to two life cycles. In fact, three quick life cycles that you want to see. So look at this. You see a mosquito. Which mosquito? Culex mosquito. Culex mosquito is the vector. Waterfowl. So these are aquatic birds which act as reservoirs, and you have pigs. Pigs act as amplifiers. And what are humans? Humans are accidental or dead-end hosts. They don't transmit it further. Who are we talking about? We are talking about JE, Japanese encephalitis. So they've asked this cycle as an image. They've asked different participants. Okay. They've also asked, if I vaccinate pigs, is that an effective elimination strategy? Yes, they will not amplify. So this is J. But don't see pigs and directly mark J. If you see pigs and you see bats, now what is it? So now we are talking about Nipah. You definitely expect a question on Nipah virus, okay? So this also came in this NEET actually, right? So Nipah virus will have these fruiting bats, okay? So these are these fruit bats, and they'll talk about this fruit here. So this is the palm tree sap that they can transmit, okay? So this is what you need to remember about Nipah. And taking off from bats now. So whenever you see bats and then you see this gorilla here and you see human beings giving it to one another, this is Ebola virus. Okay, so Ebola virus, you will see this in primates, and this can also be transmitted in humans via secretions. Okay, so these three life cycles are very, very important. Just to combine all of the antigens now. So CMV enters via integrins or heparin sulfate. EBV we have already done. Parvovirus is P antigen, already done. Rabies is nicotinic acetylcholine receptor. Rhino, you want to remember, I came to see a rhino. Okay, so that will help you. And COVID-19, I think we know it came via the ACE2 receptors into the olfactory neurons and henceforth into rest of the circulation. So this is about the entry, very important box. Now talking about BSL and bioterrorism agents. So biosafety level refers to the precautions that we need to take in a lab, right? So BSL-1 means no special precautions apart from routine ones. So this skin bacteria, yeast. BSL-2 is for normal things, don't want to talk about that. They will ask you 3. So 3 is what you need to remember is TB. Repeat question. COVID-19, very, very important. So this is when you are handling these organisms. For example, if I say culture of COVID, it is BSL-3. But if I say immunological or if I say molecular testing of COVID-19, so molecular testing of COVID-19 like PCR, I don't need BSL-3, BSL-2. So these are the two questions which have come, that molecular testing is BSL-2, whereas TB is BSL-3 and BSL-4 are all your deadly hemorrhagic fevers, right? So you will always have viruses in BSL-4. So Ebola, smallpox comes under 4. Alright, so this is what we need to remember. TB is 3, COVID is 3, but molecular is 2. That's enough. On the other hand, bioterrorism, don't mix the two. Category A, I only wanted to remember anthrax here. Anthrax is a repeat question, and then just see all things which sound deadly, smallpox, viral hemorrhagic, botulinum, plague, tularemia are all category A. Others are B. And emerging infection, this is important that Nipah, Hanta, don't put them in A. These are emerging. New infections we still don't know. So these are bioterrorism agents C. Alright, so two very volatile tables go into your choti copy. Now, few more images that we need to remember. So look at this. This is what is describing the bacterial growth cycle. So lag phase. So before you started studying now, after exam basically, your prof exam or your NEET exam, you were just in a lag. Ever since we have started BTR 2.0 cycle, now suddenly we have gone into log or exponential phase, right? So we are learning so much every day. There is so much to do, so many backlogs, right? So that's log phase. So right now what's happening? Your knowledge matlab no matlab number. So your knowledge is increasing and your size is also decreasing. You're not sitting and eating all day. So number increasing, size decreasing. But right now you're very, very susceptible. Now anybody mentions NEET PG, rank, backlogs, you get very triggered. So you are very susceptible. So this is where you have maximum metabolism and your maximum antibiotic susceptibility. Okay, so you're very susceptible, very easily triggered right now. You're working so hard. Fine. But in between, you might go into stationary phase that I don't want to study anymore. When you go into stationary phase, now what will mummy take out? Your mother will now take out her tools. So exotoxin and spore. So remember, exotoxin and spore production will happen. As soon as you become stationary, you start wasting time, these come out. And then finally, death happens. Hopefully not with us. So this is death or logarithmic phase. So this is all about the bacterial growth cycle. So whatever I've written are the questions. Log phase may number increases, size decreases, and this is maximum. Exotoxin spore is in stationary. Suman K is just an AIMS technique to properly wash hands. It's an acronym which can be tested. So, sa matlab seedha, U matlab ulta, M matlab muthi means fist, angutha means wash your thumb, nakhun means nail, and kalai means wrist. So, Suman K are the steps of proper hand washing, and hand washing is the most effective method of infection prevention in a hospital. Talking about something which has been asked twice now, very, very important. Let's say I'm doing Vidal test, okay? I'm checking antibody in a patient. If the patient has very, very high antibody levels and I do an agglutination test and still the test comes out negative, what does that mean? That is what is called as prozone phenomenon. So understand this. For us to have a positive agglutination reaction, there has to be an equivalent zone. There has to be a proper ratio of antigen-antibody. This is called as the lattice theory, right? So there has to be a proper lattice formation in order to have this agglutination positive. Prozone, if I have excess antibody in the patient, now antibody is more, so the aggregation doesn't happen. So how can we just resolve it in 1 second? Dilute the sample, dilute the blood sample, and you will have positive. Yeah. So we said this theory to an intern and intern loved it. So now what did intern do? Diluted it too much. So now opposite happened. Now you did too much dilution. So now antigen became in excess and again we have negative. That is called post-zone. So you remember answer will be prozone, intern story, post-zone, right? So this is what we need to know. Then we talk about ELISA. So these are questions which you can get in the exam. So ELISA, first of all, how many wells? So we have 96 wells in the ELISA. The enzyme which is used. So here basically what happens is whenever we have antigen antibody reaction, we are gonna detect it using this substrate. Okay. So that's H2O2. And then I have a enzyme and a chromogen. So essentially when this antigen antibody complex happens, we will have a blue color and the strength of the blue color will indicate the amount of interaction. Okay. So three things come into that: horseradish peroxidase, H2O2 and trimethylbenzidine. Okay. Right. So what is direct ELISA? Direct ELISA is where I have to detect antigen in the patient. Okay. So this is for antigen detection. Basically, we have our patient sample and I add the antibody conjugate, and if there is antigen in the patient, we can do the reaction, right? So there will be the lighting up, the substrate will happen. So basically we take patient's blood and put antibody. Opposite is indirect ELISA, where now I have coated the well with antigen and I am trying to detect antibody in the patient, right? So this is for anti. That's how I remembered. Indirect matlab anti. Okay, so let me write antibody so that you don't get confused, because in the end this will become confusing. So this is antibody detection, ANIN. So this is where we have coated the antigen on the well, and now I add my patient sample. If there is a reaction, now we add a secondary conjugate just to essentially see this antigen antibody complex. Sandwich ELISA is where again I am trying to detect antigen. So opposite of indirect, now I have coated our well with antibody and taken patient sample. So patient sample, if it has antigen, it will combine, and then I further add the antibody to detect. So basically you just want to remember we are trying to detect antigen. Competitive ELISA is where actually you can also quantitate the amount of antigen. So let's say I'm checking for testosterone. Okay, somebody has 0 testosterone, 0 antigen. Somebody has 2 antigen and somebody has 5 antigen. Here, before I put in the well, I'm going to combine all of these with my antibody. Okay, so sabse pehle we have done antibody interaction outside the well. Now, so yeah, here what we are going to do is we are going to now mix it with antibody outside the lab. Okay, so I'm mixing it outside the ELISA, not outside the lab, but outside the ELISA kit. Okay, so this I have mixed with fixed amount of antigen antibody complex. Okay, so I've given fixed antibody and now it's combining with my antigen. So let's say I gave 5 antibody, 5 antibody, 5 antibody. And now I give it one more competition antigen in the well. Okay, so now what is going to decide how much light I will have? Whatever is the antibody which is remaining will bind to the competitive antigen, isn't it? So in this case, all of my antibody is remaining because nothing could bind to it. So here we have all of the antigen which is going to react now, and we are going to have a strong positive reaction. In the second one, we have a little amount of antibody, 3 antibodies are remaining. So I will have a positive reaction, but it will be a little lighter. Whereas here, no antibody is left, so I will have no reaction. Did you understand? So this is where I can also quantitate, but it is opposite. In all of these three, the amount of light up or the intensity is going to be proportional to the amount of antigen or antibody. Here it is inversely proportional, right? So even if you could grasp a little bit of this concept, it's good enough, fine. So these are the 4 ELISAs which I have. So here basically we are testing if the neutralization didn't happen, it will bind to the antigen we have given, and that indicates that it's the inhibitor antigen which has bound to it, and our body has 0 antigen. If our body had antigen, no antibody would be left and there would be no lighting up, right? Now, this is something which are these tests which don't have a lot of meaning. So these are antigen antibody tests where you just have to remember a few words. So here, first of all, understand the difference between dimension and diffusion. Single dimension means we are doing this in a test tube. So there can only be one way. Whereas slide is when we are doing in a double dimension. So dimension means which way can the antigen antibody go. Single and double diffusion means what direction is the antigen antibody moving. So if the diffusion is happening in single direction or double direction, matlab, let's take an example of a test tube. So if there is only one way movement, that's single. If there is two-way movement, that is double, right? So single dimension, single diffusion, the test is what is called as Audin test. Single dimension, double diffusion. Like, these names are very confusing, so just remember this 2x2 table. Okay, so single is Audin. Single dimension, double diffusion means 2 names. So this is what is called as Oakley-Fulthrop test. Double dimension, single diffusion. So now single direction on a slide, something is moving. This is called as Mancini. And on a slide, if it's moving on both the direction, this is called ouch. Just remember ouch, it's ouchter Loni. Okay, so very impossible to remember. 3 of them are also O's. So Audin is 1, everything 1. Ouch is both double. Oakley Fulthrop, two names, so double diffusion. Fine, so this is what you have to remember here. So now let's talk about sterilization, a very, very important topic from general micro, which gets you usually one question in every exam. So the first thing are the methods, the temperatures for these two are also been asked. Okay, so this is important. So hot air oven, how to remember first of all, इसमें दो O's है, there are two O's, so उसके name में भी O आएगा 160. Autoclave is only one O, so no O's in the temperature. So this is 121 degrees Celsius, 15 minutes. Both of these things I could reduce. Why? Because we added pressure. 15 psi. Okay, so these numbers you got to remember. Now for hot air oven, you want to remember anything which is made up of glass, anything which is oily or greasy such as paraffin, wax. Okay, so this is what is going to be sterilized by a hot air oven. When we talk about autoclave, if you have ever been to an OT, you would have seen one sister with a drum, right? Which is sister's drum. Nobody should touch it. That drum is autoclave drum, right? So everything that comes out of it is autoclaved, right? So what all can come? All your sterile linen, OT ka sterile gown, sterile drapes, all of it come from autoclave. All your surgical instruments are autoclaved, except sharps, right? So sharps are something which are not autoclaved, and sharps कैसे sterilize करेंगे? How will we sterilize sharps? That is hot air oven. Okay, so hot air oven is where you sterilize sharps. Apart from that, sutures. Okay, although doesn't come from that drum, but you can remember together, need it in the notice. So sutures are autoclaved, except what? Except catgut, right? So catgut and chromic catgut, of course. Both of these, how do we sterilize? We can sterilize them using gamma rays. Okay, so that's gamma rays for catgut and chromic catgut. In addition, you can remember your culture media. Okay, so culture media are sterilized by autoclave, except two, which I have told you earlier as well, LJ and LSS. LJ medium for TB, Loeffler serum slope for diphtheria. Both of them have what in common is egg. They have egg in it, so we don't want to heat it, otherwise it will become omelette. So we don't want to use it. So what do we do with this? We inspisate it. So these are sterilized by inspisation, right? So this is about autoclave. Moving on to aldehydes, especially glutaraldehyde 2%. This is what we refer to as Sidex, right? It's a liquid in which you put your scopes. So this is where all of the scopes are sterilized except two scopes. So what are the two scopes? The two scopes are urethroscope and arthroscopes. Okay, so urethro and arthroscopes are sterilized by plasma sterilization. And here you want to remember one more point. They showed this company box or machine which is plasma sterilization called StirRad. So that's what you want to remember here. ETO is a gas, right? So gas se yaad rakho, cardiopulmonary machine, pulmonary, lungs, gas, okay? And all of your disposables like syringes, Foley's. If you see a syringe ka packet, it's written as ETO outside that plastic box, okay, plastic cover. So these are also sterilized by ETO. Hypochlorite 5% is used for blood spills, not just 5%, any number they give between 1 to 5%. Blood spills. Alcohol, phenol, formaldehyde. These alcohols and aldehydes don't kill spores, okay, so that's important. So these are not used for sterilization per se, they are used for high level disinfection, right? Now let's see the controls. We have biological controls, so you need to remember the names. So B subtilis, so subtilis is hot air oven. Stereothermophilus is a big name, so remember a big list, so that is autoclave. And also StirRad, kind of sounds like stereo, isn't it? So plasma or StirRad is what is stereothermophilus. Pumilis has I in it, so this is infrared rays, and G for globigi, G for ETO, gas. Okay. Last topic, pasteurization, very important from PSM point of view as well. One thing you remember, doesn't kill Coxiella, right? It's not even sporicidal, no Coxiella, no spores. Three methods. If you hold the milk for half an hour at 63 degrees Celsius, hold. This is called holder method. And what do you have to do? You have to wait. You have to wait. So remember, holder or vat. method. If I increase the temperature to 72 degrees Celsius, it gets done very quickly, 15 seconds. So this is what is called as high temperature, short time, or in a flash you could finish. Whereas very high temperature, ultra high temperature, 125 degrees Celsius, 3 seconds. They ask you what are the tests for adequacy of pasteurization. So 3 tests you want to remember: coliform, standard plate, and phosphatase. They'll give you methylene blue as the 4th test. Remember, that's not post pasteurization, that is pre pasteurization. Okay, so this is what is the important part about sterilization.